Okay, good morning, everyone, and welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal-Weiss, and I am the chair of the commission. I want to thank you for being here today. I wanted to let everyone know that the Commissioner Tina Wooten's Celebration of Life service will take place today at the Fair Oaks Presbyterian Church at 2 p.m. Several of our commissioners and staff will be attending the service to celebrate Tina's life and contributions. So we will be very focused on ending today's meeting on time. With that in mind, let's get going. The Commission Strategic Plan for 2020 to 2023 is committed to 3 strategic goals and objectives to advance the Commission's vision of well-being for all Californians. Cody, I would ask that you please bring up that slide with the strategic goals. Thank you so much. And we'd like to begin with this just to ground us as we move forward in our day. Thank you, Cody. At this time, I'd like to make a few announcements. There will be a slight change to the order of agenda items as originally noted, so we can be sure to end this meeting no later than 1 p.m. Agenda item number 5, the draft racial equity plan, will be moved to the end of the meeting and will be presented after item 6, the fiscal transparency tool. Thank you, Alameda County, for pointing out that we did not include public comment on the fiscal transparency tool agenda item. Please note that we have now included that in our agenda. The February 2022 commission meeting recording is now available on our website. Also, the next commission meeting is on April 28th, and we are hoping to meet in Ventura County. Staff is reaching out to commissioners to see if we can do an in-person meeting or hybrid meeting if that's feasible. Our goal is to get back to traveling and connecting with our local communities. In Ventura County, we are hoping to visit a school wellness center that is student-led. Really looking forward to seeing that. I want to let everyone know that the commission approved 2 innovation projects, each under $1 million, and we are really excited about these projects. So Cody, if I can have you lift that slide, please. The first one is from Stanislaus County, and it is focused on enhancing their community planning process. I'll wait for Cody to put that slide up. So, okay, I think it says on the slide Ventura, but I'll just highlight both. So the first is from Stanislaus County. It's focused on enhancing the community planning process. And the second is from Ventura County. It is focused on strengthening their full service partnership. Each had a robust community review. So we just highlighted some of those key points on those slides, and you do have more information in your packets. So thank you, Cody, for that. Next, I would like to invite Norma Pate and Tom Orrick to make exciting announcements about new staff that have joined our commission. So please, I hand it over to you, Tom and Norma.
Thank you, Chair. I just wanted to introduce to the commission today Victoria Bollinger. Victoria Bollinger's career started with the state in 1981. She has more than 30 years state experience, and she's here with us to help with our HR and personnel and recruitment efforts. As you know, the commission continues to grow, and with the additional staffing, we need more staff in our HR office. And so please join me today in welcoming Victoria Bollinger.
Welcome, Victoria.
Yes, and we have 2 additions to the Stakeholder Engagement and Grants Division, Deanna Rivas and Dan Owens. Deanna is a health program specialist, and she's focusing on supporting the Commission's early psychosis intervention efforts. She's a new state employee, and she comes to us from the Bay Area, where she spent some time working with Santa Clara County. Deanna is not new to mental health. She's both a family member of someone diagnosed with a mental illness and a former employee of NAMI, Monterey County, where she spent several years working in bilingual outreach and their programming. So we're happy that she'll be able to continue her work in the mental health field here at the commission. I also want to welcome Dan Owens. Dan is also a health program specialist, and he'll focus his work on the Mental Health Student Services Act grants. Prior to coming to the commission, he was at the Department of Developmental Services. Dan has a master's degree in counseling, Master of Science in Counseling, and has provided therapeutic services to children and youth in school settings, which would be very helpful when he worked at Stanford Youth Solutions here in Sacramento. Dan's been jumping right into the work, and that we're doing with the county partnerships, and so we're very happy to have him on board as well. So we're happy to welcome Deanna and Dan to the team.
Welcome, Deanna and Dan. Happy to have you here. And we look forward to the contributions you will offer the commission. At this time, I would invite Chair Alvarez to make an update or to provide us an update on the CLCC committee.
Thank you very much. Hello, everybody. Just want to let you all know that the Cultural and Linguistic Competency Committee met on March 10th. We focused on the challenges of local organizations serving marginalized communities, including communities of color, LGBTQ, and others, particularly challenges related to sustainability, and how through our work as a commission and in partnership with the CLCC, we can identify opportunities to strengthen investment in local leadership. The bulk of our time together was dedicated to a presentation by the Prevention Institute. The commission had allocated a portion of its $2 million COVID relief funding to the Prevention Institute. This is an organization with a solid reputation for listening to the concerns of historically marginalized populations regarding access to appropriate mental health services. The Prevention Institute's Associate Director, Ruben Cantu, shared the goals of the project and the work being done so far to hear from key stakeholders about the funding challenges and the strategies for identifying common ground between county behavioral health departments and diverse populations. So the goal of this contract really is to engage county behavioral health leaders on the opportunities to adapt, extend, and replicate the work of effective local organizations in developing and testing the effectiveness of community-defined evidence-based practices, which we've heard a lot about both at the CLCC as well as this commission. And as we all know, these are specifically designed to meet the needs of communities of color. Together during that meeting, we all agreed that the CLCC will serve as a critical thought partner in this effort. So we committed to having Ruben Cantu come back to future CLCC meetings where we can hear updates on the findings, including the recommendations that his project will present to the commission so that the CLCC can provide input on such recommendations. Again, it's an effort to coordinate OAC activities in further support of our equity goals, which obviously we'll hear about as part of our Racial Equity Action Plan. The next meeting of our committee will take place actually in April. Right now it's on public in the website as scheduled for May 12th at 3 p.m. But we're actually adding another meeting in response to some committee member interest to connect with each other as committee members and to have greater discussion around our committee goals, including providing guidance to commission activity. Given the release of this draft Racial Equity Action Plan, we see it as a timely opportunity to have the CLCC's input as we look to approve the plan in the future. And I look forward to seeing many of you guys there. Thank you.
Thanks so much, Commissioner Alvarez. Appreciate the update and all the work that you're doing with the committee. I'm going to move on now to the Children's Committee update. As a reminder, our former chair, Lynn Ashbeck, initiated the Children's Committee and outlined two goals. One was to enhance the integration of the Commission's work on children's mental health, and secondly, to support the Governor's Children and Youth Behavioral Health Initiative. I have appointed former Commissioners Ashbeck and Barrick, and I'm happy to share that Commissioners Bontrager and Carnevale have also accepted to serve on this committee. At this time, I would like to invite both commissioners to share a few words about this opportunity. So please, if I could have Commissioner Bontrager and Commissioners Carnevale just share a few words about joining this committee.
I would just say that a lot of my work is very focused on children. I'm passionate about children because if we can improve the conditions at the beginning of our life journey, then a lot of the issues in that journey will become less. So I think it's the right place strategically to put a lot of effort, and I'm really excited about this committee and trying to figure out how to help connect all of the pieces across the system to help the children of California.
Thank you, Commissioner Carnevale. Commissioner Bontrager? I don't see him or hear him. So we will move on. I'm sure he's trying to log on here, so we will continue to move on. Please note that I am working with staff to develop a work plan for this committee, and we will share that with you all as soon as we have that prepared. Now to public comment instructions. If anyone is interested in making public comments regarding the announcements or other items, please make those during the general public comment time. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. Lastly, if you have any technical questions, please contact Amariani at amariani.martinez@mhsoac.ca.gov. At this time, I will ask Amariani to go over the public comment procedures.
Good morning.
Good morning.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue. The moderator will insert the word "last comment" next to the commenter's name or number to identify the last public comment. So please make requests to comment as early as possible. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. Chair Madrigal-Weiss, I hand it off to you.
Thank you, Mariani. With that, again, I would like to welcome everyone to today's meeting. Recognizing that teleconferences can be challenging, the plan is to end at 1 p.m. At this time, Maureen, I would ask that you please take roll.
Commissioner Bontrager. Commissioner Boyd. Commissioner Brown.
Here.
Thank you. Commissioner Bunch. Commissioner Carnavale.
Here.
Thank you. Commissioner Chen. Commissioner Carrillo. Commissioner Chen. I'll come back. Commissioner Carrillo. Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Here.
Commissioner Mitchell.
Here.
Commissioner Roulette.
Here.
Commissioner Tamplin.
Here.
Vice Chair Alvarez. Vice Chair Alvarez.
Here.
Thank you. Chair Madrigal-Weiss.
Here.
Commissioner Chen. We have 8. We'll proceed.
Thank you.
Yeah, we'll establish quorum as people get here.
Thank you, Maureen. It is now time for general public comment. This time is reserved for comments on items that are not on the agenda. Again, I would like to remind everyone, if you wish to make public comment, click on the raise hand button or your computer or the app. Or if you are calling in by phone, press 9. If you would like to comment on a specific agenda item, please wait until that agenda item starts, then raise your hand or push star 9. Once the public comment period for the agenda item starts, we will close the public comment queue. So please make any requests for general public comment now. Please be prepared to complete your comments within 3 minutes or less. If there are any members of the public using translation technology, please let me know and we will make sure that you have sufficient time to make public comments. Mariani, please open the line for general public comment.
We currently have 3 commenters. Stacy, your line, oh, all right, Stacy, your line is open. You may go ahead.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I'm very pleased today to ask you to save the date for a very exciting event taking place on Thursday, April 28th from 12:30 to 1:45. So only just a little over an hour, right after your regular OAC meeting next month. This is in conjunction with the annual meeting of the California Reducing Disparities Project and is a very special celebration since the approval of the $63 million to sustain and extend the CRDP last year. We really hope you'll join us at this virtual celebration and update of the project, because you'll also learn some initial findings from phase 2. I'll be sending you more information, including the Zoom access, but in case you have any questions, please do not hesitate to contact me. On another note, I realize the subject will be covered later in the meeting, but I would like to mention both AB 1668 Patterson, which affects the makeup of this commission. I'm quite sure that Assemblymember Patterson's office is working with the former commission chair, Lynn Ashbeck, so I hope this bill will be discussed at some point by the commission. In addition, SB 970 Eggman proposes significant changes to the MHSA, particularly at the county level, and I hope the commission will consider taking a position on this bill also. Thank you very much.
Thank you, Stacy.
Next, we have Marianne. Your line is open. You may go ahead. Oh, sorry. You're still muted, Marianne.
There we go. Greetings to the new commissioners and welcome back to the old ones, especially Commissioner Brown. I am Marianne Bernard. I am a retired lawyer, and in retirement, I advocate for the severely mentally ill, which is the group the MHSA was actually adopted by the voters to help. Here to remind those of you working on PEI once again of the mandate placed by the voters in the original MHSA. Mandate means it uses the term shall, and that means it is not optional. At 5840C last clause, which requires PEI funding for the prevention and early intervention in relapses of people who already have severe mental illness. In other words, PEI isn't just for people who are not yet severely mentally ill. It is prevention and early intervention in the relapse process as well. A couple of you have been here long enough to remember perhaps that the Office of Administrative Law forced the commission to include relapse prevention in the existing PEI regulations, even though the movers and shakers didn't want to do it at the time and tended to treat the statute like a rough draft because it is a mandate. And if the commission feels as it did in the past, or at least a majority do, that this is not important, it will be much easier to arrange for the OAL to make you do what you are supposed to do the second time around than it was the first. So bear that in mind. Finally, I want to remind you that there is a very easy way to comply with this mandate without having to do much, simply by sending PEI money to 2 programs that are already in the MHSA at 5813.5F. The first one is Laura's Law, which is quintessentially, early intervention in the relapse process of people who have a recent history of dangerousness. And the second, and at the moment, far more important program that has always been part of the MHSA, but has been largely ignored both by this commission and by the counties, is funding for diversion and reentry programs for severely mentally ill inmates who are either headed into or out of our local jails. There is a crisis now at the local level stemming from recent California court decisions that are telling counties that individuals considered incompetent to stand trial, IST, by virtue of mental illness, cannot simply be stacked up like logs, usually in solitary confinement where they suffer horrifically. But they must be evaluated within 29 days or you have to let them go. So there aren't enough beds to evaluate them. And there are some pending legislative attempts to fix this, but it's not going to work. These diversion and reentry programs are desperately needed, and they can easily be funded by the MHSA and by PEI money.
Thank you, Marianne. Your time is up. Please wrap up.
So I hope you will do the right thing and also use your imagination and your experience to come up with more programs for relapse prevention and early intervention in the relapse process for people who already have existing severe mental illnesses. Thank you.
Thank you, Marianne.
Okay, the last commenter we have is Ale. Your line is open. You may go ahead.
Thank you so much. Good morning. My name is Ale Fernandez Garcia, they, them pronouns, and I am with the California Pan-Ethnic Health Network. I'd like to thank the Commission for taking an explicit racial equity lens when thinking about the innovations component of their racial equity plan on page 4 and 5 of the plan. We know that California's public mental health system does not adequately serve Black, Indigenous, and people of color and LGBTQ+ communities. BIPOC receive insufficient prevention and early intervention services and core mental health programs that often lack cultural and linguistic appropriateness, and COVID-19 has exacerbated consumers' need to care across the board, but most programs have not been designed and tested with populations truly reflective of California's diversity. So to address these disparities, CPEN, Out for Mental Health, and the California Primary Care Association published a report in 2018 that looked explicitly at how to center racial equity through innovations, from which the plan has adopted those recommendations. So again, we'd like to thank the Commission for incorporating our recommendations.
All right.
Thank you very much. Thank you so much.
Thank you, Alej.
And
Claudia,
that was our last comment.
Thank you so much. Thank you, members. For those of you that made comments, again, every time we hear from you, it makes us better and we appreciate them. With that, we will move forward to item number 1, approval of the February 24th OAC meeting minutes. The Commission will consider approval of the minutes from the February 24th teleconference meeting. At this time, members of the public may request to make public comment on item 1 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Commissioners, are there any questions or comments regarding the minutes? I see none. Are there any public comments? Please raise your hand now as the queue will be closing.
I don't believe there's any public comment.
Thank you. At this time, then, I would ask commissioners if I have a motion.
So moved.
I'm sorry, Commissioner Alvarez.
And I'll second.
I appreciate that. I think we are still waiting for a couple of our commissioners to log on. So at this time, we will move forward until we have that quorum. And we will come back to this. So thank you, noted Commissioner Alvarez and Commissioner Carnevale, but we will continue to move on. So thank you for that.
Here, We do have Commissioner Chen, I believe. Her microphone is turned off, so if we could just come back to roll, I would like to ask once again. for roll.
Yes, I've managed to
Commissioner
get
Chen?
myself unmuted.
Okay, thank you. Then we
Perfect.
do have a quorum. We have 9, we have a quorum.
Okay, do we need to take roll again, though?
No, we're fine. We have quorum.
Okay, thank you. Then let's go ahead and take the vote. So Commissioner Alvarez made the motion and Commissioner Carnavale seconded the motion to approve the February 24th meeting minutes. So Maureen, do you now want to
with
take?
the vote on the minutes,
Yes.
please? All right.
Yes.
Commissioner Bontrager, Commissioner Boyd, Commissioner Brown.
Abstain.
All right. Commissioner Bunch, Commissioner Carnavale,
Yes.
Commissioner Carrillo, Commissioner Chen,
Approve.
Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Roulette,
Aye.
Commissioner Tamplin,
Abstain.
Vice Chair Alvarez, Vice Chair Alvarez, Chair Madrigal Vice.
Approve.
Thank you. The motion passes.
Thank you, Maureen. Let us now move on to our second item on the agenda, which is Kern County Innovation Plan. For agenda item 2, the commission will consider approval of approximately $8,700,000 in innovation funding for Kern County's mobile clinic with the street psychiatry project. We will be hearing a presentation from Christina Rajalal. I hope I pronounced that correctly. And if not, Christina, please, when you start your presentation, you will do that for me, who is the Behavioral Health Program Supervisor at MHSA and MHSA Coordinator for Kern County Behavioral Health and Recovery Services. Commissioners, you were provided with the staff analysis and PowerPoint for this presentation, and the materials are also posted on the MHSOAC website. We're excited to discuss the innovation plan. Members of the public may request to make a public comment on item 2 by clicking the raise hand button on your computer or the app, or by pressing *9 on your phone. Once the public comment period starts, we will close the public comment queue. So please make requests to comment now or as early as possible during this presentation. Thank you for joining us today, Christina. We would like to hear a high-level overview of the needs in your county, which prompted this innovation plan, how the plan will address the needs, and how you plan to measure the outcomes. To ensure we have enough time for discussion, we ask that you limit your remarks to 5 minutes so that we can focus on questions and discussion with you. At this time, I hand it over to you.
Thank you and good morning. Thank you for inviting us to speak on behalf of Kern's Mobile Clinic with Street Psychiatry Innovation Plan. My name is Dr. Christina Rajlal. My pronouns are she, her, hers, and I am the Mental Health Services Act Coordinator for Kern County. Next slide, please. Kern Behavioral Health and Recovery Services acknowledges that we sit on the homelands of the Yokuts, Paiute, Chumash, and Mono people. We pay respect to all ancestors and native populations and appreciate their sharing of this land, and for us to continue to support people in their mental wellness and recovery journeys. Next slide, please. So why are we here today to talk about what's going on in Kern County? Well, we have a big problem that we're trying to solve in Kern County, and that is during the pandemic, we have had numerous barriers to reaching our clientele and providing psychiatric and behavioral health care. On top of that, the homeless crisis within Kern County has grown. 8,030 adults in Kern County needed housing supports. Of that amount, 1,432 were classified as families or adults with children. Additionally, 2,825 individuals needing housing support were youth. and 17 of those individuals that were youth did not have a guardian attached. 43% of these total populations identified having mental health or substance use challenges. So that points us to the solution that we're here to propose to you today, which is the Mobile Clinic with Street Psychiatry Plan. This plan will offer 2 mobile clinics, outreach and treatment team, person-centered mobile wraparound support, outreach and engagement, linkage to community support, food and hygiene supplies, housing linkage, peer support, street psychiatry, intake, assessment, case management, behavioral health and substance use counseling, and medical triage and services, including medication refills, intramuscular injections, and Narcan distribution. Next slide, please. So we want to talk about what's not working in the county. And honestly, what's not working are the traditional clinic-based behavioral health services for populations that truly are disengaged or fearful of the system or government, or just overall are lacking resources. Additionally, unreached populations, including unsheltered individuals, transition age youth, and youth that are identified as commercially sexually exploited children. I'd also like to bring your attention to the Board of Supervisors in Kern County have identified a local homeless and substance use crisis within Kern County and the Metro Bakersfield area. So how does our innovation project address those problems that we've identified? Well, we are planning to use the relational stages of outreach and engagement model known as ROAM, which we plan to use to test the effectiveness in engaging with people facing homelessness. This is a phased approach of outreach and engagement. And we also are looking at building 2 customized psychiatric mobile clinics that will bring services to where the clients are located on the street or even in the riverbed. We're also proposing to fund staffing, including 2 peer support specialists, 2 therapists, 1 psychiatrist, 1 medical assistant, 1 nurse, and 1 recovery specialist. Next slide, please. So community contribution and collaboration is at the heart of every single thing that we do in Kern County and the utilization of Mental Health Services Act funding. Kern held 29 different stakeholder community forums that assisted in the development, shaping, and molding of this proposal that you're seeing today. And I'm happy to tell you that the stakeholders in Kern County have voted in favor of the Mobile Clinic with Street Psychiatry Innovation Plan. Next slide, please. So what are we hoping to learn and how do we plan to measure this? Well, we have 3 different learning goals here. The first learning goal is, can the mobile clinics with street psychiatry increase quality of life factors for individuals facing homelessness? And we plan to measure this using a satisfaction survey instrument with an outside evaluator. The second learning goal is, can the use of the mobile clinics with street psychiatry increase the use of available care? We will be doing data tracking on this to count and track the willingness to engage or accept services from the mobile clinics. And the learning goal number 3 is, can the mobile clinics with street psychiatry provide more outreach and access to care on the street? And we're looking at tracking enhanced linkage to services, including the use of medication and successful housing placement. Next slide, please. So today, Kern Behavioral Health and Recovery Services seeks approval for the use of $8,774,098 in total innovation funding to launch the mobile clinic with street psychiatry innovation plan for the period of 5 years. Next slide, please. And with that, I'd like to thank you for your time today. Please take a look at our wonderful blueprint of one of our build outs of the customized behavioral health units. And I'd like to entertain any questions that the commissioners may have at this time. Thank you.
Thank you so much for that breadth and depth in 5 minutes. That was excellent. Thank you so much. Appreciate that. Commissioners, at this time, I would ask, are there any questions or comments regarding the plan?
I have a couple of questions. Sorry, I always miss where the hand raised function is. 2 questions. The first is probably more to staff. Has this kind of program been deployed anywhere else in the state that we've either supported or are aware of?
Is that question for me or was that for?
Probably somebody, I'm guessing somebody on staff that would have.
I would ask,
Words. Yeah.
Charmel, would that be?
Yes, we have several mobile clinic models. So what's that we have across the state? There's one in Riverside County, and there are some in we have one in LA County. So yes, across the state there are several. What's unique about this particular one is the psychiatric the fact that it's focused on psychiatric services, which is a little bit different from the other ones. And we also have others that are more wellness based versus, you know, medical and wellness. So there's a little bit of differences, but yes, some of them do have this program across the state, and we have discussed those with the county.
Great. Thank you, Charmel. My second question to the presenter, thank you for indicating the collection of data. I think that's a really important element of these programs. My question for you is, after this gets deployed and the money gets spent, what would success look like?
Yeah, that's a wonderful question. You know, we are really trying to reach our hard to reach population. Those are the folks that are not coming into our clinics, especially with the pandemic. So these are our folks that are we're really focusing on those facing homelessness or are unsheltered. And so this is really the best way to kind of focus on what it is it's basically we're putting our clinic completely on wheels and we're going to the population to support them. And so, you know, in engagement and medication and interaction with doctors, doing actual street psychiatry with our psychiatrists on the street, popping up a table, pulling out 2 camping chairs and having one-to-one interaction and engaging with this hard to reach population. This is what's really significantly, you know, different from the other models that currently exist throughout the other counties. And a lot of this is going to show success on the number of counts and interactions we have and how many people are truly engaged. We know in Kern County with like our head counts, it takes about 17 interactions with somebody that is unsheltered or facing homelessness before they'll receive services or interact with our staff. And so really trying to fight the stigma, you know, against behavioral health and substance use support. So counting those touches of individuals within, you know, within our county and our Metro Bakersfield area that we're interacting with, that we're building those relationships with using this model of the Rome approach, and then how many are accessing treatment, care, or other resources that behavioral health provides. And so that is really what success will look like for us. And we're really excited to be able to bring that because we see it all across our county that this is a huge challenge. Thank you for that question.
Well, thank you for that. This approach makes sense to me, especially since we long ago have closed all the facilities to treat people that have these issues. I guess what I would like to see as part of the proposal and funding is, since you're going to all this trouble to measure all the data, I would like to see you actually set some objectives. What are reasonable objectives that you would expect out of the program that we can measure against, which is not to say that there is going to be any particular result of it, but it's nice to know where we would like to go so we know at the end of the program how well we've done against what we hoped the outcome would be. And that I think that's just good business, as I would say.
Thank you. And if I can follow up with that question, the first year of implementation, we're really looking at setting the baseline, right? The baseline. So we have already in existence within our Kern behavioral health care is, you know, our homeless outreach programs, and we do a lot of phenomenal work in this area. Transportation and getting to people and where people are at has been a significant challenge we've seen for many years that our stakeholders have stated. And so this really is looking at that model and building on what we know is successful in our other programs that focus on the same type of population and expanding how do we bring these services to them, creating that baseline of the first year of implementation, and then trying to raise the success bar from that point on. So I really appreciate that. I think we're in alignment with the vision of where we want to go with the model.
Yeah, that's great. If we could just attach some numbers to that as an objective, that would be great. And I'd ask our staff to consider putting that into program if this is approved, which I would be in support of. Thank you.
Do I have,
Please.
I'm sorry, if I just have a second to follow up as well. The original proposal that we submitted, and I know it's pretty lengthy, but we do have a target number to be served annually, which would be 12,635 individuals. And those are broken down in different components like service delivery, the medical model, intramuscular injections, outreach approaches, medication refills. So there's all these categories in the larger plan, and the total that we're looking to serve annually would be 12,635. And that's really based off of some of the information and data that we have from some of our other programs that serve the same population.
So that's great to see what number are served. I guess I would also like to know what are the outcomes we hope that will happen versus what's happening today. You've identified we have a big problem. How much better would we get to if this system was deployed?
Thank you. And I think that is one of the measurement pieces with using Rome, is really using that as a tool to see if this model truly is going to engage individuals and help to, solve part of the challenge that we're having in Kern County. I really appreciate those comments. We will take them back.
Thank you.
Thank you, Commissioner Carnevale. Any other commissioners, questions or comments regarding the plan? Commissioner Mitchell.
I just have a quick comment. I love the model and I love the outreach for this population, because I think this is the work. This is the hard work. This is the stuff that we really can do well when we put this type of effort into it. So going out, looking for these people, because these are folks who probably don't have addresses. So I applaud your effort. My question is, so how are you going to get your population in? You said you're going to go out to them. You mentioned like going down to the riverbank. So are you going to, as you said, put some chairs out and drive the mobile clinic in? So is this going to be word of mouth? But I definitely applaud the project and I totally support it. But I do want to know, how are you going to, really, really get this program where folks on the street know about it, considering the number of folks that are living on the street that fit this model?
Thank you, Commissioner Mitchell. And I'd actually like to invite our administrator over our Kern Linkage Division programs on, and that's Michelle Cooley. And she can talk a little bit about what the engagement and the outreach component really looks and feels like. I think she can give a really great description of that. And that's Michelle Cooley.
Hi, thank you. Yeah, so it's actually really exciting. We already have some existing referral networks that we have with our outreach workers. We work a lot with law enforcement. We get a bunch of community referrals, family referrals. So it just, and then they really do go out in the community and they work with one of our partners. It's called Flood. I'm not sure how familiar they are with Flood, but it's a great partnership that we have where we go out together and we just kind of conquer all the challenges that we have, and we just really go out and engage with individuals. And we do, sometimes they do just go around and the intent of the program is to take the units and to go out and look in the community and see the individuals that are really struggling and not able to actually physically go into a clinic. So this would be this is filling a missing gap. So it's going to be great.
Well, I love the model. I really, really appreciate this this presentation.
Thank you. And
Thank
if
you.
I can jump in, Commissioner Mitchell, one of the things that I like to add to is that we have 2 customized mobile units that we're talking about. One is like a larger RV, those typical kind of RVs that you've seen that have been kitted out. But then we have a smaller one, which I would kind of equate to those Sprinter vans that you're seeing on the freeway of all those wanderlusting individuals. And that one's going to be outfitted so that it actually can kind of get down closer to like the riverbed area, where we know with the RV, you can get it down the riverbed, but you may not be able to get it back out. So these two mobile units will look a little bit different, and it's to help with that geographical consideration of being able to implement this plan and really reach people.
Thank you. Commissioner Mitchell, were your questions that we're good? All right, thank you so much. Commissioner Rolette, please.
I want to make one comment, and I apologize. I'm on a mobile device, so I hope I'm being heard clearly. I was looking at the budget, and I appreciate staff analysis. And because these are 5-year plans, my comment is that wanting to make sure that the budget is sufficient into the future years to maintain or satisfy the goals of the project. What I often appreciate about the budgets is they don't take into consideration all the inflation factors that we are experiencing today. And so my hope is that staff at Kern County have taken that into consideration or have some contingencies in place should, and probably in all likelihood, as I glance at the budget, when the expense associated with maintaining the program exceeds what's being allocated for the future years.
Thank you. And I would like to bring on our finance manager, Candy Del Rio, and she can speak a little bit more about the sustainability planning of the budget.
Thank you. We appreciate the commissioner's interest in the sustainable viability of this particular program. One of the things that we do anticipate being able to do to add money to the $8.7 million budget is Medi-Cal billing. So that would allow us to leverage additional funds. There is also the possibility with the way that we do our innovation funding planning, that there would potentially be some programs that don't utilize all of their funds, and we could also use some of that funding from unutilized funding from other programs in this program as well.
Thank you for the answer.
Thank you. I see Commissioner Rolette was your comment. Okay. I see your hand going down. Your comment was addressed. Your question was addressed. Perfect. I see no other questions or comments from my fellow commissioners. I'm sorry. It's hard to see you back there. Yes, Commissioner Kaplan, I think that's your voice.
It is. Thank you so much for this opportunity to comment on this innovation plan, and thank you, Kern County. I appreciate the inclusion of peer supporters, and this approach of meeting people where they're at, and eliminating barriers of transportation and access to services, especially access to peer support. I am curious because this is definitely a very clinical approach that's psychiatrist focused and medication focused. So I'm curious about how the peer supporters will be able to be in their specific role, because the recovery model is about meeting the person and mutuality where they're at. So when someone that's homeless and is struggling with mental health issues and wants that peer support but doesn't want the injectables or medications, how will you support that person?
Thank you for that. Thank you for that question. That's a really wonderful question that leads me to really highlight that Kern really has peers integrated throughout all of our system of care. And so with this approach, the outreach and engagement approach is so significant in making this successful, that the peer component will definitely be evident in those approaches. But as well, we also have built into this like our recovery specialists and substance use counseling, behavioral health counseling, and peers are really well utilized in those areas as well. Like you just said, is like being able to connect somebody with somebody that has that lived experience and has walked in those shoes. That is something that Kern County, we've adopted that a long time ago. We already do have our peer certified programming that we've had for many years called our PET program. And we're looking at leveraging that program to help support us with being able to provide these two peer support specialists that will be paid competitively. And so we're really happy to bring that component. I don't know if there's additional details that you needed on that, or if you could expand.
I appreciate, I think what I was just hoping also to, or was wondering about was whether there's a concern, now that we have peer support certification moving forward and we'll be able to bill Medi-Cal, we want the system to understand the role of peers and not to be mini clinicians, because the evidence is in being able to just really be the advocate for the individual and then help them, with whatever their goals are, their life goals and their strengths, right? So, when you're in a setting with, and I've worked in these settings also, and this one's a mobile setting, so I haven't worked in a mobile setting, but, there's a heavy clinical team, and just making sure that the other staff understand the role of the peer, a supporter, and being able to speak up around issues that might be not aligned with what the clinical staff think, but aligned with what the individual wants.
Yeah, thank you for that. And I'd actually like to invite our Deputy Director, Robin Taylor, to come on and speak a little bit more specifically, because I think she can tailor to your point exactly. So Robin.
Hi, yeah, thank you. I really appreciate that question. I think the great thing about this program and the Rome model is that we're actually in integrating the peers is it's really more the Rome model and what we're doing out on the street. It's more the peers are really going to be comfortable and it's their type of work. And it's the medical staff that are going to be learning from the peers in that engagement model and really learning how the skills and the work that the peers do in building those relationships and aligning and working where the person is. So I see really, you look at the medical staff in this role, and they're looking to the peers and they're looking at all of the work that the peers are going to be doing and learning from them. And so I think when we look at the individuals who are working on the street, our flood ministry staff, our outreach staff, a lot of them have lived experience. And our physicians and our clinical staff who have seen the amazing work that they've done and their expertise and have seen the work and the success that they have, they are now looking and starting to mimic that engagement. And so I think this is such a great opportunity that now the clinical staff, it's kind of interesting, the clinical staff are really learning from the peers and are getting really excited to shift their work and start engaging more. And so we're excited about this. We have integrated a lot of peer support in the work that we do. And of course, the clinical staff that we hire and work in this role will be absolutely are thrilled and want to do this community street psychiatry. This is their passion in this work. So we're excited to have this going. And I hope what we're seeing is really the clinical staff in this situation is really switching more into non-clinical words. They're not, they can't really use the clinical terminology. They're using the recovery terminology. They can't really, they're focusing on engagement. They can't really jump into prescribing medication. So it's a really switch in roles, and they're really looking to the peers in the recovery model to work on that engagement. So it's really fun to see.
Thank you, Robin. Commissioner Tamblin, does that answer your question?
It does. Thank you.
Thank you. Commissioner Brown, I understand you had a question or comment?
Yes, thank you very much, Madam Chair. So First of all, just a comment and just to commend Kern County on this project. I'm very pleased to see the mention of the relationship with law enforcement and the collaborative effort that can come of that through referrals and whatnot. Also, the inclusion of peer support, as mentioned, and particularly pleased to hear that you're incorporating the Narcan distribution with this, since this population oftentimes is victim of opioid overdose, and very glad to see that. I do have a question, and that is in your stats. You mentioned that you have 8,300 people in need of housing support. Of that 8,000, do you have a point in time count, or do you have an estimate of how many are actually homeless? And follow up to that question is, do you anticipate that 2 mobile clinics like this will be adequate to support the homeless population in your county?
Thank you. Thank you for that. The couple of questions there. So the data that we pulled was from our HMIS system, which is our homeless management information system. And it's a huge report. I could go back and I could find the specific data points, versus homeless versus chronic homeless. And I don't have that at my fingertips right now, but it is the report that we pulled this data off of. And it is the report that we read through to start to write and prepare our innovation plan. So we do have that, and it is significant in our county. That was the first question. And then, I'm sorry, can you repeat the second question that you had?
Well, I don't know that you're going to be able to answer that if you don't have. The question really is: is it anticipated that these 2 mobile clinics will be adequate for the chronically homeless population, the people that you're talking about, I think primarily using this to reach?
Right. Thank you for that question. So, and I do want to mention and highlight that we do currently offer additional services that support this population. So this is to expand and enhance really another component of what we think that we need for homeless outreach and engagement, and to try to initiate with individuals that may need our services. And so really the test is to test and see what the success is with this model throughout the 5 years. And then if we find that it's successful, we will have to move it into a sustainable planning mode and look at expansion efforts and where we do that. This really does fall in alignment with our FSP, and it truly is preventative care as well. So there's already internally, we have identified that if we move to sustainability, which is what the ultimate goal is, that we would be looking at those additional funding streams for long-term funding and possible expansion of units if needed.
And then just one last question. The photograph that you have of the van shows that the livery that you have for it is, I assume, your agency logo with the name Behavioral Health and Recovery Services on one side of the van and not on the other. And I can certainly see that you want to market with something, but perhaps not put anything that's going to stigmatize or prevent people coming to get treatment. But so if that was the goal, I think you've done quite a nice job in terms of finding that balance.
Thank you so much. And, I would love to speak just a second on this. And we received some significant feedback from our stakeholders. Don't brand it versus branding it. And so what we've decided to do is have those huge removable magnets where we can pop our logo on if we go to an outreach event, especially if it's an outreach event that is focused on this population. We can go out, have our vans, have people see what the model looks like. And then when we go out and we need to be more discreet about care and reaching out and really trying to engage with individuals, those can pop off and they can be just white vans.
Great. Well, thank you. Great job.
Thank you.
Thank you. I see no other comments or questions from my fellow commissioners. I can't really see in that room there at the OAC office, but I think we are good to go. If somebody can just give me a thumbs up. No more comments there. Thank you so much. Christina, I appreciate the proposal. I very much appreciated that you included data before and during the planning. I thought the objectives were very clear and appreciated, how you use data again to inform the process. So I really appreciated that. I also liked very much that the referrals can come from law enforcement because they are out there, and also from the families. So, many of our youth, they're experiencing substance use. They're not going to come into a clinic. And the fact that you're going to go out to them and provide them the care that they need, we're seeing such an increase of, everything that's going on, the fentanyl use and everything else that's happening. So I thought going out to where our youth and our, everybody really needs it. I thought you're being really responsive. So thank you for that. And thank you for this plan. So with that, I am going to ask if we have public comment, and I see that we do. And so Christina, we will take public comment. This is for you to just listen more than dialogue and take note of what is, what we're going to hear from the public. So with that, I'm going to ask Amarani to open up the lines, and let's get started with that process. So thank you all.
Okay, we have currently 10 public comments. Jan, your line is open. You may go ahead.
Good morning. My name is Jan Hefner. My pronouns are she and her, and I'm the administrative consultant with the Center for Sexuality and Gender Diversity. We're a 501c3 nonprofit in Bakersfield. Our mission is to provide affirming care and services to LGBTQIA+ individuals and to build bridges to educate the community at large about the needs of our population. Our direct care services at the center include counseling, support workshops, and youth engagement. We formally partnered with Kern Behavioral Health and Recovery Services since July of 2020, and we have found them to be staunchly committed in their words and actions to improve services to the most marginalized residents in our county, including learning about and providing affirming care to our LGBTQIA+ community members. And we're honored to support their proposal for innovation funding to create this new and much needed mobile clinic with street psychiatry. We've seen studies estimating that 40% of unsheltered youth identify as LGBTQIA+, and family conflict has been identified as the most common cause, usually because of the youth's sexual orientation or gender identity. And we know that being in a community remains important to unsheltered youth, and that information is routinely shared about where the safer encampments are. Providing supportive care in the manner described will surely save lives. The Rome engagement method is key to reaching unsheltered persons to meet them where they are, taking the time necessary to build trust, and then bridging a person into services and care at their pace. This approach gives us great hope that these mobile clinics will be able to positively impact hundreds of lives in our community. And we are certain that the Kern Behavioral Health and Recovery Services staff will provide the same affirming care for our LGBTQIA+ community. Thank you for your time, and I look forward to hearing of your approval for this program.
Thank you, Jan.
Sharon, your line is open. You may go ahead.
Good morning, Commissioners. I'm Sharon Woolfolk. I'm president of NAMI, the National Alliance on Mental Illness here in Kern County. NAMI is the nation's largest grassroots mental health organization. We provide education, support, and advocacy for all persons affected by mental health challenges. For the past 43 years, NAMI has been advocating to improve the quality of life for everyone affected by mental illnesses. Now more than ever, our homeless men, women, young adults, and at-risk youth who are living with mental health challenges and substance abuse challenges need our help. They need a community that will work together for mental health. They need a community that will be proactive, supportive, and actively involved in their lives to make life better for them. The increase in homelessness coupled with the growing mental health crisis has made it difficult for us to provide supportive services and link individuals to much needed services. The Mobile Street with Street Psychiatry Project is the answer. Without a doubt, The mobile clinic will eliminate the transportation barriers and other obstacles that prevent individuals from getting to their scheduled appointments and picking up their medications. But more importantly, it will address each person's overall well-being. For too long, we have sat in our offices and expected these individuals to come in and get the help they need, but they're not going to come in. We need to meet them where they are in the streets. We need to provide them with the services they need. They need food, they need shelter and medical services, and more importantly, they need to know that they live in a community that cares. Delivering mental health services and providing medical assistance to those experiencing homelessness shows that we care. I'm confident that this project will have a positive impact on people living under the bridges, in our parks and alleys, and behind our local businesses. Now, this mobile clinic staff will be trained. They'll be trained to meet the specific needs of those experiencing homelessness. And this specialized team will be able to develop some relationships, some deep relationships, and provide the essential services, which include a variety of supportive services, psychiatric evaluations, therapy, medication management services, all of which will contribute to the overall well-being of individuals. If not this innovative mobile clinic with street psychiatry project, then what? The need for mobile services to help our homeless throughout Kern County is now. Thank you in advance for your thoughtful consideration, and thank you for the opportunity to speak.
Thank you, Sharon.
Jim, your line is open. You may go ahead.
Thank you, commissioners, for the opportunity to speak about this project. My name is Jim Wheeler. I'm the Executive Director of Flood Ministries. We are the primary street outreach provider in Kern County. We have about 11 teams that go out throughout the city of Bakersfield, Metro Bakersfield, and then all 8,200 square miles of Kern County. And it's been our observation that it's just a struggle. It's a struggle for people in the outlying areas. You know, traditionally, in our point in time count, about 20% of those who are experiencing homelessness reside outside of Metro Bakersfield. And there are very few resources available to them. You know, Kern County, the geography, we have hills, we have valley, we have mountains, and we have desert. And it's very difficult for those folks who who are experiencing homelessness, who have behavioral health needs, to get to Metro Bakersfield. It's from some locations, it's a 3 or 4 hour drive. And so this mobile team, this project, I think, will be very helpful in taking the services to the people that need it. And so we support it, and we ask that you would support it as well. I have noticed a need for some time for a street psychiatry and for medication support team. That's a gap that's been in our system of care, in our continuum of care. And I applaud Kern Behavioral Health and Recovery Services for trying to fill that gap. We know that from our data that we collect and we report out to BHRS and also to our continuum of care, that about 65% of those who we engage with on the street every day self-report mental health issues, and about 60% report substance use disorder issues. So there's a great need. Earlier, the riverbed was mentioned. We know that there are currently there are 92 encampments on the Kern River bed. Those encampments are made up of 2 or more people who have, I don't like the term service resistant, they have high intensive needs, and most of those are behavioral health needs. There are folks that can't go to our navigation centers and can't go to our shelters. And so the need is there to take the service to them. And so I would encourage you to support this project. I think it's going to be a much needed resource in our community as we tackle this issue of homelessness. So thank you for your time.
Thank you, Jim.
Golongo, your line is open. You may go ahead.
Thank you so much for the time and opportunity to speak in support of the Innovation Project. I am the Medical Director of Kern Behavioral Health and Recovery Services. I'm also the Child and Adolescent Psychiatry Program Fellowship Director of the UCLA Kern Residency Program, and I'm also the Research Director there too. One of the things that is very in short supply is the availability of psychiatrists. And more, there's need for recruitment and retainment. One of the needs of those who are going through psychiatry training is that they really want to go out and make a difference. They want to connect, they want to serve, and they really see a need. So what we have noticed is that the relational outreach model has allowed not only for the development of the opportunity for those who are in training to go out, but also to give them an awareness of the needs that are in the community. Now, more than ever, the fellows and the residents want to be a part of this, and they do want to learn from the peers. They do want to understand how to make a difference. They want to go out and do the psychiatric evaluations, medication management, order the labs, make sure individuals are connected with medical services, understand that it's a matter of having first contact, showing compassion, and winning confidence, because everyone knows that the therapeutic alliance is instrumental in healing. And having made that bridge and formulated that confidence, then individuals are willing to listen and willing to be open to other services. I think it's a privilege above all privileges to meet individuals where they are. And as was stated before, if not us, then who? And if not now, then when? I think this is an idea that has come at the right time, a time of dire need. And I feel that Kern Behavioral Health and Recovery Services has a track record of reaching out to those who need. I came here as a trainee and I stayed on through over a decade because I believe in this system and I believe in this care model, and I can really see it making a difference. Thank you for your time.
Thank you, Golongo.
Juan, your line is open. You may go ahead.
Hello, my name is Juan Padilla. Can you guys hear me?
Yeah.
Okay, I understand there's probably like a few questions if it's gonna work. And that's something that everybody should think about. But there's also a high chance that it can. So there's a lot of youth that don't want to, they give up. They don't want to think about what they could do for themselves. A lot of them like want to help each other. Like there's a lot of, whenever there's somebody in the same position, like they try to help each other as much as they can throughout Kern County. Flood could only do so much. And Flood is linked with the mission. And I see a lot of people at the mission on 821st Street. They're doing their best, but they could only do so much, but if they had one of those trucks like right in front of the mission, and there's just always people there, and there's always a way to, go get help of whatever they need, I think it would benefit Kern County a lot. Like there's like 47% of our youth unemployed. So they don't know what to do, you know? So I believe what the other guy said, you know, if not us, who, you know? Because, you know, I've been homeless a few times. There's been times where like I didn't know what to do, but at the same time, like there's been outreaches, not with Flood, but the Dream Center as well, you know? The Dream Center and Flood, they do their best, but there's only so much they could do if somebody's trying to go to Flood or go to the Dream Center and they don't have transportation, and they don't, you know, they don't even have a phone. Like our societies run around phones. Like we need to be able to contact a lot of our peers, you know, and I don't see how it can't work, but we could give it a try for sure. It sounds beneficial for a lot of our society, you know, and that's all I gotta say. So.
And I appreciate your perspective and speaking to the youth and being authentic with that. So thanks for sharing that story. Thanks for your perspective. Really appreciate it. Thanks for being here.
Next, we have Lauren. Your line is open. You may go ahead.
Good morning, Commissioners. My name is Lauren Skidmore, and I am the CEO of the Bakersfield Homeless Center and Alliance Against Family Violence and Sexual Assault. And I speak in support of the County of Kern's Behavioral Health Innovation Project today. We operate the only facilities in our area that focus on families experiencing homelessness, as well as domestic violence, sexual assault, and human trafficking trauma. We see thousands of women and children through our doors each year, and we know thousands more exist that are not seeking services that this project could identify. We must meet our residents where they are. Kern County is home to over 8,000 square miles of diverse landscapes and cultures. We have over 900,000 residents, with more than half being Hispanic or Latino. While many challenges lie hidden within our community, the innovative spirit does not. We are home to some of the greatest entrepreneurs, inventors, scientists, and passionate, heart-centered leaders who aim to transform the mental health crisis we face today. I work daily with the homeless team at Behavioral Health, who is responsive, trained, and kind in the way they treat the diverse homeless population. They assist us with the individuals who are fearful or anxiety-stricken and cannot thrive in our sheltered environment. I support this project, and myself and my team look forward to assisting this project in whatever ways we can. Thank you.
Thank you, Lauren.
Anna, your line is open. You may go ahead.
Thank you so much. My name is Anna Lavin. I'm the Executive Director for the Bakersfield Kern Regional Homeless Collaborative, and we operate as the continuum of care for Kern County, which is a HUD requirement for the region. Our primary objective is to provide strategic direction for addressing homelessness in Kern, all 8,000 square miles of it. One of the pieces that we regularly put together is a plan to end homelessness in Kern County. And one of the things that I wanted to make sure that I mentioned for all of the commissioners here is how much we're excited about this project, because it directly feeds into a number of the objectives that we have listed throughout our plan to end homelessness. Kern Behavioral Health and Recovery Services is a very strong partner with us. They regularly have representation on our governing board. They assist with our homeless management information system and in a whole host of other areas and committees. But one of the objectives that I in particular wanted to highlight in our plan to end homelessness is objective number 3, which is to improve the economic security, health, and stability of homeless and at-risk people. And one of the goals that we have under that objective is to ensure that mental health and substance use treatment services are readily available to eligible homeless people. And I think you've already heard from a number of our community organizations and folks who can really speak well to the idea that this is an incredibly vulnerable population, and it's challenging for us to get to folks in a traditional treatment format. And that's one of the things that I think really excites us about this particular project. I know that a number of you had asked about data. A lot of data was already presented. I would also mention that for our 2020 point in time count, which was just right before COVID hit our community and of course across the country, we in that 2020 PIC count report for those with mental illness, 29% of homeless adults reported a history of treatment and or hospitalization for a serious mental illness. And what I would like to highlight is that 86% of whom were unsheltered. And so I think this really drives home to the idea that we absolutely must, if we are going to be successful in addressing the needs of those who are experiencing homelessness, we absolutely have to take opportunities for service to those individuals. I think has already been described, Kern County has a lot of various territories to try to cover. We have urban and suburban, and then of course we have rural communities as well. We have a lot of encampments that have been growing, in particular along the riverbed areas. And so this is just a really fantastic way, I think, of us trying to think creatively and work in partnership together. So that way we can try to address those needs. Thank you.
Thank you, Anna.
Hannah, your line is open. You may go ahead.
Hi, good morning, everyone. My name is Hannah Bickoff, Policy Director at Cal Voices. I'll keep it brief. I just wanted to voice my support for this plan. I think it's fantastic and does a great job of addressing the complex needs that present from the unhoused population. It's just really refreshing to hear sort of innovative approaches like this grounded in community support. It's just so clear that so many local stakeholders have come forward really appreciating and feeling that this plan addresses the issues that they're actively seeing going on. And I think it is also sort of a good model of the ways in which community-based voluntary services can be effective, in light of some of the more statewide movements towards involuntary coerced treatment. I just want to uplift this as a model that can and does work in communities, and I'm really thrilled to learn more about it. So thank you so much.
Thank you, Hannah.
Jamie, your line is open. You may go ahead.
Good morning, everyone. My name is Jamie Stewart, and I'm the coordinator for the Kern County Network for Children's Dream Center. The Dream Center is a one-stop resource and drop-in center for current and former foster youth and homeless youth up to age 25. We also provide street outreach and housing services for homeless youth. There are currently 259 youth who have been certified as homeless in Kern, and many more who are out there alone. There is a compelling need for the mobile clinic with street psychiatry services that Kern Behavioral Health and Recovery Services is proposing today. A study from the National Center for Children in Poverty found that homeless youth are vulnerable to physical and sexual victimization. More than a third met lifetime criteria for post-traumatic stress disorder. 45% of males and 28% of females experienced assault with a deadly weapon. 42% of females experienced sexual assault. Nearly 1 in 5 attempted suicide, and more than half had suicidal thoughts. We routinely see homeless youth who have been beaten, robbed, hurt, and are in the throes of crisis. They experience trauma after trauma, and they want to give up. It's a current practice for them to self-medicate with illegal drugs when they're off their medication, and they are magnets for human, drug, and sex traffickers. The youth who will benefit the most from these services are the ones whose phones aren't reliable since they are routinely stolen, who are rarely oriented to date and time, lack transportation necessary to get to appointments or pharmacies, and or lack the skills necessary to follow up on appointments. Research tells us that it takes as many as 17 interactions to connect to mental health services. This project will help Kern change that. The homeless youth we work with have taught me that the only thing worse than no services are services that aren't helpful because they aren't accessible or client driven. Our youth need these services and will use them. I urge you to approve Kern's mobile clinic with street psychiatry project. It will help improve quality of life factors access and use of available care, and make it possible for us to help increase successful housing and decrease homelessness for our youth. We thank you for your consideration and wholeheartedly support this proposal.
Thank you, Jamie.
Avery, your line is open. You may go ahead.
Sorry. Thank you so much. Hi, everyone. Good morning. My name is Avery Hulag Vicente, and I am the advocacy coordinator for CAMPRO, the California Association of Mental Health Peer-run Organizations. CAMPRO supports models of care that highlights the value of peer-led services and services that meet people where they're at. So understanding where the gaps exist in resources like transportation, housing, and behavioral health services, especially in these rural areas of California. So thanks for developing and presenting a thoughtful and intentional plan to address these gaps in services. I believe that it's long overdue. But I do echo the concerns of Commissioner Tamplin regarding the role of peer providers in this mobile clinic model. Peer providers have the knowledge, the expertise, the professionalism, and the empathy that is necessary to provide quality and effective care for those who have mental health needs and are experiencing mental health crises. Although peer-led services are included as part of your model and the makeup of the team, CAMPRO hopes that their role is honored and respected among the other members of the mobile clinical team, and that their advocacy and work is implemented in serving this community. So I appreciate your time, and thanks so much for allowing me to speak.
Thank you, Avery.
Chair, that was our last official public comment. There were two that came in after. Would you like to take those?
Okay, that's Dahlia and Julie. Yes, we'll go ahead and take those. I would ask that you make those brief just because you are after the time that we took all public comments. So let's go ahead and do that then.
Okay,
I'm
Dahlia,
ready.
your line is open.
Thank you. I appreciate that. My name is Dahlia Fontaine. I'm the homeless healthcare administrator for Clinica Sierra Vista, and I'm coming to you on behalf of Clinica Sierra Vista and the street medicine team that's led by Dr. Bear as Director of Special Populations. We have a small team here that treats the chronically unsheltered patients since 2019. We work under the mantra to go to the people, which essentially means we go to them in their encampments and to, abandoned buildings, street corners, anywhere we can find them where we can engage. And we want to be able to support Kern BHRS and this mobile unit because we see the need on a daily basis. Our providers, our staff, those who are clinical and non-clinical, go and we try to engage, but the lack of resources that we may have or the trust that we are building with this population would be most impacted with a mobile unit like this. We just don't, we just want to be able to support this. We feel extremely strongly that this is something that our community needs. When we're out on the street with these patients, we're treating them very broadly. We're, looking at not just the medical need that they have in gaining medication or maybe wound removals, but we're looking at them and trying to understand why they've isolated themselves psychologically, mentally, emotionally, socially, and spiritually. If we have a unit like this, we know that the success rate will be high. We know that we will be able to support them in a larger sense than what we can do in the medical clinic or just by one medical provider. So we support them. We are honored and delighted to be able to present to you our support to them, and we look forward to seeing the successes if this is approved. Thank you.
Thank you, Dahlia.
Julie, you may go ahead.
Thank you. And thank you, Madam Chair, for allowing us to speak in support. I'll just say the Steinberg Institute is here today to throw its support behind this innovation project, and we urge your approval. Thank you.
Thank you, Julie. Appreciate that. And I thought I muted myself. Okay. So At this time, I would ask if we have a motion from my commissioners.
Chair
Madrigal-Weiss.
Chair Madrigal-Weiss.
Oh,
I'm sorry, did I skip a step? What did I do?
Oh, no, I was just going to comment.
Okay, please.
I just really want to extend our appreciation to the public comments. We talk a lot about approaches to equity in our work. And I think one of the fundamental principles of equity is to allow those most impacted by the problems to lead our solutions. And that showing of public comment on this proposal was direct evidence of that. And I just want to really appreciate the work that Kern County is doing with its community partners and lifting up their leadership as an example of that commitment to equity. And with that, I move to approve.
Absolutely. Thank you, Commissioner Alvarez. Do I have a second?
A second.
Thank you, Commissioner Mitchell. Are there any additional questions or comments from the commissioners?
Just one question about, I really want to uplift what the public comment from Juan Padilla around phones. And was curious if, because we are in this innovation plan, there is going to be administrating medications, and the reality of the side effects of those medications are real too. And because Juan pointed out that individuals don't have access to phones, and then how to communicate if there is a side effect that is, especially with long-term injectables, how to get that communication to the team is really on my mind. And so I don't know if Kern County can speak to providing phones for folks that are part of this program.
Thank you for that comment. And I will say that one of the pieces that you'll see in the plan is that we're planning to partner with a lot of community-based partners, a lot that actually, spoke today or that we have continued partnerships. And one of the things that we do as well is try to partner with resources. So it's not something that we have planned in our proposal to provide phones, but there are a lot of services that are available that provide the free phones and having that linkage. So we've been asked in many different platforms, like through the stakeholder process, can you add a component? Can you add a component? And what we do know is that some of those components exist in our county, and what is really key is us partnering with them so that we can bring them along with us, and we can plan to do that with the use of the phones and increased communication. So thank you for bringing that to us.
Thank you.
Thank you, Commissioner Templin. So I have a first, I'm sorry, do we have a second? Yes, Commissioner Mitchell, is that correct? Yes, thank you. And so any additional questions or comments? Commissioner Templin, any other questions or comments? Look, I see none. So Chief Counsel, I would ask that you take roll on the proposed motion to approve Kern County's innovation project, the mobile clinic with street psychiatry. And there it is on screen. So
yeah, there it is. Okay, certainly. Commissioner Bontrager, Commissioner Boyd, Commissioner Brown, Commissioner Bunch, Commissioner Carnavale.
Approved.
Thank you. Commissioner Coelho, Commissioner Chen.
Approve.
Thank you. Commissioner Cortese, Commissioner Danovich, Commissioner Gordon.
Aye.
Commissioner Mitchell.
Approved.
Commissioner Rolette.
Aye.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Vice Chair Madrigal-Weiss. Chair Madrigal-Weiss.
approved.
Thank you. The motion carries.
All right, congratulations, Kern County. We wish you the best and hope to hear about your success, and to your entire team. Everybody was on it with their answers, knew exactly how to respond. So that just speaks volumes to the planning, and to all the community that was here present. Appreciate that. Appreciate the backing of your County Behavioral Health Department. So thank you. Take good care. Have a wonderful rest of your day. It's a good one. And with that, we are going to go ahead and move forward on to item number 3, legislative priorities. Next, the commission will consider approval of legislative and budget priorities for the current legislative session. Norma Pate, Deputy Director for the Commission, will present Assembly Bill 2281, authored by Assemblymember Tom Lackey, that would create the Mental Health Preschool Services Act to be administered by the Commission. I am thrilled to see legislation introduced that focuses on the needs of our very young children. Members of the public may request to make a public comment on item 3 by clicking the raise hand button on your computer or the app, or by pressing *9 on your phone. Once the public comment period starts, we will close the public comment queue, so please make requests to comment now or as early as possible during the presentation. Norma, I invite you now to please present on AB 2281.
Thank you, Madam Chair. AB 2281 is modeled after the Mental Health Student Services Act and would create a grant process to improve access to services for children ages 0 to 5. If funding is made available, it would authorize the Commission to release this funding to support the mental health needs of our youngest Californians. The Commission has been able to use grant funding like, oh, yes.
Hi, Norma. I'm sorry. I don't mean to be rude and interrupt you. I just want to be mindful of, I know an important day that we have ahead of us for many of our commissioners and for many of the public. So I wanted to see if, for my fellow commissioners who have received these materials and read over the materials, if I could just make a motion to support AB 2281 and direct you all to work with the author's office and the policy committees on the bill. And I only say that because we've had this conversation about the importance of supporting our young people, our students, and also our youngest Californians, our babies and toddlers. And clearly, we've been able to use grant funding like the Mental Health Student Services Act and triage to strengthen services. We've talked at length about this population, and I know we voted on these types of opportunities before, so want to encourage us to move forward with this, support the bill in concept, and direct you all to work with the authors and the policy committees in order to move it forward, just in the interest of time and recognizing the day ahead of us. Hopefully that was okay.
That works for me.
Thank you, Vice Chair Alvarez. So do we have a motion for that?
Can I move? I would like to move to support the bill in concept. And then
I'm pleased. This is Dave Gordon. I'm pleased to second that motion. This is a real hole in our system now as we move forward in K-12 that really needs to be plugged so that we start where we should be starting in the 0 to 5 space.
Thank you. So we have a first and a second. Before I get to public comment and the vote on this item, are there any other legislative items for us to consider? I ask that of my fellow commissioners. Any other items for us to consider? Okay, then I would ask, seeing none, I will ask if there are any public comments regarding this. I see some, so please raise your hand now as the queue will be closing. This is a reminder that members of the public should be prepared to complete their comments within 3 minutes or less. Please note, the meeting moderator will unmute your line and announce your name or the last 3 digits of your telephone number. Once unmuted, we can hear you. Amirani, I would ask that you please open public comment. For agenda number 3. Thank you.
Okay, we have 4 comments. Angela, your line is open. You may go ahead.
Great. Thank you, commissioners. My name is Angela Vasquez. I am the Policy Director over Mental Health at the Children's Partnership. I will keep my comments brief. I just wanted to call and express support for increasing MHS OAC investments in infant and early childhood mental health, such as through the proposed Mental Health Preschool Services Act and AB 2281. Young children under age 5 can and do suffer from mental health conditions. These conditions are difficult for providers to identify and address because young children handle emotional experiences and traumatic events differently from adults and older children. So during these early years, a child's brain is developing more rapidly than at any other point in their life, and they are also uniquely dependent on the adults in their lives to meet their social emotional needs and bounce back from stressful experiences. The Children's Partnership looks forward to working with the MHS OAC and our coalition of infant and early childhood mental health advocates to ensure expansion of infant and early childhood mental health care through the MHS OAC, as well as other state investments. Thanks so much.
Thank you, Angela.
Hannah, your line is open. You may go ahead.
Hi, good morning. This is Hannah Bickoff again, Policy Director at Cal Voices. We'd also like to support the concept of this bill. The preschool population and younger children within the public mental health system are obviously a very vulnerable and high needs group with a very limited amount of available targeted and specific services. However, with AB 2281, we do have a couple of concerns and things that we think may be missing and intend to send a letter to the author's office really quickly. And most importantly, I think there needs to be explicit call out to the ethnic and racial disparities within this population and the ways in which the young Californians, especially at preschool age, at this point in their education, can often be routed to the school to prison pipeline unless very specific outreach is targeted towards BIPOC populations within this demographic. So we believe that specific language should be added to address the needs, the unique needs of BIPOC preschoolers and their families. Secondly, we believe that within the demographic, there should be specific outreach for children of incarcerated parents, and that further supports should be available to that particular group. And lastly, and very, very importantly, there is no mention of collateral or family work within the bill, which we know is an evidence-based practice and of course, extremely meaningful for young children, that the work cannot be just with the child in their daycare or preschool facility, but it must engage the entire family. So we intend to share those comments with the author, but wanted to make them known today. Thank you so much for your time.
Thank you, Hannah.
Stacy, your line is open. You may go ahead.
I'm sorry, I have to ask, is this just on AB 2281 or is this on all the legislative topic? I'm sorry.
2281.
Oh, okay. I'll make it really short. I just want to support all the comments of Hannah Bickoff, and I think that this bill has very good intent. Thank you.
Thank you, Stacy.
Rachel, your line is open. You may go ahead.
Okay, hi, how are you guys doing today? I'm Rachel Rodriguez. I'm Civil Rights Coordinator for the NAACP, but I'm also here on behalf of SAR. So that's the self-awareness and recovery. They do a lot of mental health. I have a comment on behalf of the small nonprofits. You know, we have been delivering services that such as violence prevention, trauma-informed healing, mental health to adults and system impacted and at-risk youth and in the underserved communities for years. How do we ensure that these essential organizations and nonprofits are included in your funding? They've been and continue to do the work of these counties and schools that you've dispersed money to in the past. And today we haven't directly felt the impact of the money that has been dispersed. So what criteria is needed to gain a seat at the table, and that we can ensure that our programs keep going on, that our kids and our adults are directed and this is impacting them, so we don't, repeat the cycle in our community.
Thank you, Rachel.
Okay, next we have Maria. Your line is open. You may go ahead.
Okay. Good morning, everyone. Maria Wyatt from Imperial County Behavioral Health. I'm a manager at one of the children's programs. Seeing this bill gets me, I'm very passionate with young children. As you know, the commission approved our innovation project, the first step to success, back in 2013, and we transferred it to a transition to a PEI program. We've been providing services in the school site for TK and kindergarten children. We're in most of the schools here in Imperial County, and we're providing already services at preschool. We can't provide it in the preschool because preschools and daycare, require some, vaccination requirements from their staff. But we are providing the services at their homes, and we have a parenting component in our program. So with this is just going to augment services to the young children. So I'm all for it, and more services to the 0 to 5 is awesome. So, and Imperial County will embrace it. Thank you.
Thank you, Maria.
Okay, that was our last public comment.
Thank you, Amirani. At this time, okay, we have a motion and a second on the Mental Health Preschool Services Act. So are there any additional questions or comments from our commissioners? Seeing none, I would ask Chief Counsel to please take roll.
Commissioner Bontrager. Commissioner Boyd.
Maureen, could you turn it up a little? Because it's hard to hear you.
Sorry, can you hear me now?
It's a little bit better. If you could turn it up just a little bit more, please.
Is this better?
That's better.
All right. Commissioner Bontrager. Commissioner Boyd. Commissioner Brown.
Aye.
Commissioner Bunch. Commissioner Carnavale.
Yes.
Commissioner Carrillo. Commissioner Chen. Commissioner Chen. Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Aye.
Commissioner Mitchell.
Approved.
Commissioner Rolette.
Aye.
Commissioner Tamplin. Aye. Commissioner Alvarez.
Aye.
Chair Madrigal-Weiss.
Approved.
The motion carries.
Thank you, Maureen. So we have come to a time that we are at break. So everybody stretch your legs, get your coffee, do whatever you need to do to take care of yourselves. We will be back in 10 minutes. So it is, what time is it? It is 10:51. We'll come back at 11:01. Let's do that. All right. See you soon. Thank you. Welcome back, everyone. It is 11:01. We'll get started. We are now at item number 4, the Mental Health Student Services Act outline and authority to award grants. At this time, I will be recusing myself and will have Vice Chair Alvarez lead the meeting during this item. So with that, I pass it on to Vice Chair Alvarez. As soon as she pops in, I'll pop out.
Hello, I'm here.
There we are. I was going to
I'm
start
so
talking
sorry.
about. No, I was going to start talking about March Madness, but here you are.
I'm so
Okay,
sorry.
it's all good. With that, I recuse myself. Thank you, Vice Chair Alvarez. You've got it.
Great. Welcome back, everybody. Thanks so much again. I hope you had a nice break. You got to stretch your legs, got some water. I am now feeding a very hungry baby, which is why I'm off camera. So bear with me. So the next item on the agenda is the Mental Health Student Services Act outline and authority to award grants. The commission is going to hear a presentation by Tom Orrock, Chief of Stakeholder Engagement and Grants, and we'll consider approval of an outline and authorization for commission staff to enter into contracts to release the balance of the Mental Health Student Services Act fund. Just as a quick reminder and some background for folks, funding for these grants was made available by the Mental Health Student Services Act, Senate Bill 75, statutes of 2019, and Senate Bill 129, statutes of 2021. This request for application for MHSSA funding will be the third issued by the commission. I want to again remind our members of the public that you may request to make a public comment on this item by clicking the raised hand button on your computer or the app, or by pressing *9 on your phone. Once the public comment period starts, we plan to close the public comment queue. So we ask if you could please make your request to comment now or as early as possible during the presentation. So with that, I will hand it over to Tom to begin, please.
Madam Chair Alvarez, Vice Chair Alvarez, this is Dave Gordon. I will recuse myself on this item.
Thank you, Commissioner Gordon.
Okay, great. Thank you, Vice Chair Alvarez and commissioners. I'd like to provide a very short background on the MHSSA, or Mental Health Student Services Act, because I think you're familiar with this program. And then I'll outline the plan to provide the balance of MHSSA grant funds to implement new programs and expand the existing programs. So we can go to the first slide, Cody. Thank you. In 2019, the commission was provided $40 million one-time and $10 million ongoing to establish partnerships between behavioral health departments and schools, specifically behavioral health departments, school districts, county offices of education and charter schools to establish school-based mental health services. We can go to the next slide. These grants are meant to primarily incentivize local partnerships to ensure that students are able to receive much needed mental health services at what is probably the most strategic location we have in our counties to provide access to services, which is schools. So the grants provide funds to meet the needs of our most at-risk students and vulnerable youth in these locations. And next slide. As Vice Chair Alvarez stated, the Budget Act of 2019 and the Budget Act of 2021 provided the Commission with $270 million to distribute to partnerships to address the stated goals. After the first 2 rounds of funding, we've distributed just over $207 million in grants to 55 counties and dedicated a portion of the funds to staffing, evaluation of the programs, and technical assistance. Next slide. So after round 1 and round 2, there's a balance of just over $48 million. So because we'd like to see all California counties, right now I said we have 55, we'd like to see all California counties included in this program. So we're recommending that we provide another opportunity to the 4 counties listed here on this screen, or on this slide, to receive a grant. These 4 counties do not have grants, so maybe I can explain a little bit of that. It's important to note that these previous RFAs were released in the midst of the pandemic, as well as 2 wildfire seasons. And so these greatly affected the ability of these small rural counties to respond to the application. One of these counties applied in round 1, but later decided they were not ready to implement a program, and the other 3 have not applied for funds in either round 1 or 2. So we recommend that we provide another opportunity for them to receive funds. They'd be eligible to receive $2.5 million over a 4-year grant term. And then we would be giving them 4 months at the start of the grant period to develop their programs. This effort will require a total of $10 million of that $48 million. And then second part of this is that we would recommend that we make the remaining $38 million available to the current grantees to augment their programs. They would provide us with a plan for how they would expand or enhance their current programs and submit an updated budget. We would then award grants and add funds to their current contracts. This would save us some time, save us a couple of steps in the contracting process, and would allow us to get the funds out near the start of the next school year. We'll go to the next slide. We conducted a survey with our current grantees to gauge their interest in the balance of funds. We wanted to make sure that there was still interest out there and there was opportunities to expand these programs. 90% of the current grantees indicated that they would apply for additional funds. They indicated that they would most likely use these funds to expand services to more students by expanding services to more school districts. They would enhance youth voice in program development and operations, and they would expand the current service models, typically through screening, suicide prevention efforts, and dropout prevention efforts. So we can go to the next slide, which will be the time frame. This is the time frame that we anticipate. As I stated, our goal would be to execute the contracts and amend the contracts by September of this year. So the proposed motion on the final slide is that the Commission authorizes the staff to initiate a competitive bid process and award grants to the highest scoring applicants based on the proposed outline. I'm happy to take any questions. Thank you.
Thanks so much, Tom. That was a really helpful overview. I especially appreciated your 3 points about where county interests are in using the expanded fund. So really appreciate that. Thank you. At this time, are there any commissioner questions or comments? And just also at the same time, if I could encourage members of the public, if you are planning to make a public comment, to put yourself in that queue. But are there any commissioner questions or comments? Well, I'll just take the liberty of asking you, Tom, to that point that I just made about the 3 areas of interest from counties. Is there any specific plan for OAC staff to help address those particular interests or connect counties with existing counties, making these types of efforts possible? Can you talk just a couple more minutes about that?
Yeah. One of the things that we have begun already with our current grantees is collaboration meetings. We've had a few of these already. And in the collaboration meetings, you know, the best part of that is that counties are able to interact with one another. So we learn a lot about the county programs and who's kind of doing what. We found that most of these programs are conducting a few different kinds of things, but generally they're falling into areas like, we have a group of grantees who are operating wellness centers. We're going to be down in Ventura County seeing one of those, we hope in April. Others are really focusing on screening. Others are focusing on the partnership itself and the best ways to build out this partnership and sustain these partnerships after the grant period ends. So with these new counties coming on, these new grantees coming on, we would be able to connect them to those like programs, so that if they had an interest to expand and potentially open a wellness center or have screen more students, we'd be able to connect them to counties that are doing that work, so that they can learn from past experiences. Our first round, we had 18 grantees. The second phase of that was 19 grantees. So we have 37 programs that have been up and running for a bit now. And so we hope they'd be able to learn from each other in that way.
Excellent. Thanks, Tom. Appreciate that.
I have a quick question.
Please.
Commissioner Mitchell. So these 18 and 19, I'm just curious, Tom, because I know we had a short little meeting about this or discussion. Are they actually, the counties, are they actually up and running with programs in the schools? I mean, do we have any really great models? You mentioned this, you know, these drop-in centers or, you know, but how are we ensuring that the schools are really getting the help that they need? Do we have any best practices programs out there?
Yeah, I think the greatest assurance for programs being relevant in the school is that this is a partnership. And I think this is the cornerstone of these programs. To have the school district in conversation and in planning with the behavioral health departments and the county offices of education and charter schools or other partners, I think we have some assurance that these programs are going to be relevant. They're going to be the programs that are needed most. There's a lot of leeway in the act for what counties could or grantees could, these partnerships could do with these funds. And so I think what we're seeing is that they've chosen these areas that they think are most important for, you know, to help students in their schools. I think the pandemic affected a lot of this and really guided a lot of the work that they're doing. We know that schools are screening students, and so we know that they're offering other programs to connect them to services, navigating students and families to the services they need. And so we're learning a lot from that. And so it'll be really helpful to have this additional funding so that the counties can, you know, expand those services or enhance those programs. What we have is we have sent demographic data sets out to the counties who have been operating for a bit now, the first 18 and then the second 19 set of 19. So we're beginning to receive data on who's been served, how they've been served, what kinds of services they've been referred to. And so we'll be collecting that data just to ensure that we are targeting students who are vulnerable, who are most at risk, as the act has required.
Thanks, Tom. Thanks for the question, Commissioner Mitchell. Any other commissioners have any questions? Okay, so let's move on to public comment. This is a reminder that members of the public should be prepared to complete your comments within 3 minutes or less, please. Also, please note that the meeting moderator will unmute your line and announce your name or the last 3 digits of your telephone number. And once unmuted, we can hear you. So with that, I'm going to hand it over to Amariani to please open the line for public comment on this agenda item.
Okay, we have 2 public comments. Elia, your line is open. You may go ahead.
Thank you very much. Elia Gallardo with the County Behavioral Health Directors Association. First, I want to thank the Commission for its efforts, both in helping to secure this critically important funds and also for helping to get those dollars to where they need to be, basically the schools. Pre-pandemic and actually since the beginning of time, county behavioral health agencies have been working in schools. It's where the kids are. It's where we want to provide our services. So to the question of Commissioner Mitchell, we would love to give you more information on the many promising practices that we've had historically in serving in schools. We have an extensive footprint pre-pandemic. 85% of our providers were doing school-based services. 70 were covering over 50% of the school districts. The pandemic hit, and many of the referrals that we were typically receiving from school staff and personnel, those were reduced because children were no longer in schools. The infusion of the MHSSA funds could not have come at a better time, considering the circumstances and the pandemic and children going back to school. Kids returned, and again, they returned with increased behavioral health needs associated with isolation and trauma that they've experienced through the pandemic. We again want to thank the efforts of the Commission in looking at this issue and looking at those remaining funds and providing some additional support for those small counties that are obviously, because of their size and some of the circumstances, we definitely hope that those counties will be given additional support to secure those funds. We also want to express our support for the efforts to expand on the existing grants and to build on some of those promising practices that the MHSSA is building upon. And finally, if possible, we'd like to see if AB 638 changes might influence this and allow for the expanding of some of these resources to support substance use disorder services. Thank you.
Okay, next we have Rachel. Your line is open. You may go ahead.
I'm going to make the same comment that I made earlier. Hi, my name is Rachel Rodriguez. I'm a civil rights advocate for the NAACP. I work with LULAC, and I'm here currently representing SAR, Self-Awareness Recovery Program. My question is that programs like us, programs like SAR, are already doing this stuff out in the community on behalf of these counties. They're doing stuff that is delivering services to underserved youth and communities and at-risk youth, such as like violence prevention, trauma-informed healing, mental health. You know, these are system impacted and at-risk youth. And we've been doing it for years, but we are not directly affected or feeling the funding that you are currently giving out to counties and schools, although we're in these schools. So what my question or my comment is, you know, in order for us to continue to do the work that is essential and that these counties are relying on in order to get your money, how do we get a seat at the table or ensure that we meet the criteria so that we can apply for these grants or these funding as well, because we're actually doing the work?
And that was our last public comment.
Thank you, Amariani, and thank you, members of the public, for your comments. At this time, I just want to move forward and acknowledge the work that went into these funds, Tom, by you and the team. I think a lot of us admire these funds and what they're doing in our community. And with the announcement of this additional investment, these multiple opportunities, there's a lot of pressure, right, to make sure that return on investment is being seen in our young people, given the mental health crisis that we're seeing amongst our children and youth. So I really appreciate the work that's being done at the OAC and on the ground in our counties with partners, of course, together, and looking forward to hearing some of the shifts that are hopefully being seen over the next few years to protect the well-being of our young people. So with that, we do have a motion that needs to be proposed. And this is to authorize staff to initiate a competitive bid process and award grants to the highest scoring applicants based on the proposed outline. Do I have a motion and a second?
So moved.
Okay. Commissioner Carnevale and Commissioner Mitchell. Was that right? Yes. Okay.
Yeah.
Sounds good. Any additional questions or comments from our commissioners? Okay, Chief Counsel, will you please call the roll?
Commissioner Bontrager. Commissioner Boyd. Commissioner Brown is recused. I'm sorry. Commissioner Brown?
Aye.
Aye. Commissioner Bunch. Commissioner Carnevale.
Yes.
Commissioner Carrillo. Commissioner Chen.
Approve.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Recused. Commissioner Mitchell.
Approved.
Thank you. Commissioner Roulette.
Approved.
Commissioner Tamplin. Aye. Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss is recused. The motion carries.
Thank you, Maureen.
You're welcome.
So with that, I'm gonna hand it back over to our chair if she is available. And if not, we will move forward. All right, the next item on the agenda. We have 2 items left. Oh, there she is.
I am back, but you're doing a great job. So you want to keep it rolling. I think I got it. Okay, thank you, Vice Chair Alvarez, for facilitating that agenda item. We have 2 more items left. Next is a presentation on the fiscal transparency tool. So last month, I asked staff to provide us with an update on the fiscal transparency tool. As you may know, the state is forecasting MHSA revenues to reach $3.8 billion. And the pandemic has stressed our communities and increased the need for services quite dramatically. At this time, the economy is strong and we have more funding than we've ever seen before. Yet the commission has received comments that despite the additional revenues, the services are not growing as fast as the needs. We will hear from Executive Director Toby Ewing and Phoebe Bell, Director for the Department of Behavioral Health in Nevada County and the President of the California Behavioral Health Directors Association. We welcome you and thank you for joining us today, Phoebe. At this time, members of the public may request to make public comment on item number 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Toby, let's go ahead and get started.
Madam Chair, and I'm gonna rely on Cody to help with the presentation. He's going to share the screen. Probably 4 years ago, maybe 5 years ago, we presented to the Commission a way to display as up-to-date fiscal data as we could, as was possible with the existing data. We had designed this display based on conversations that we had with partners from the community. At that time, the Commission had a fiscal oversight committee. And we engaged our partners around what information would be relevant and helpful to support the community engagement requirements of the Mental Health Services Act. And so the Commission developed what we refer to as a fiscal transparency tool that highlighted revenues, expenditures, and available funding. And the reason for that is because the law says that as part of the community engagement process, there needs to be an opportunity for the public to understand the funds that are available for future expenditure. A couple of years ago, we did not update the report, the fiscal transparency tool, because we didn't have up-to-date information and because our county behavioral health partners raised concerns with the way in which some of the data were portrayed. And so Commissioner Ashbeck asked us to engage county representatives and community leaders and try to get a handle on the concerns that were raised. And so Phoebe Bell from CBHDA will speak for the counties better than I will, but one of the issues was they wanted to reflect that while counties often keep unspent balances available, they do so because of exceptional volatility in revenue. They do so because under 3-year plans, they've got future year commitments. And they asked us to make some modifications. We've addressed many of those concerns, but not all of those concerns. And at the same time, we had not updated, we had not put the tool back online. And so what you see in front of you is an updated version of the Commission's fiscal transparency tool. And we just wanted to take this opportunity to share some of the modifications that were made and to present the information to the Commission and to see if you had any concerns. Our intent is to repost this information on the Commission's website, barring any significant concerns from the Commission. So what this display shows, and if you can scroll down just a little bit, Cody, is basically these 4 boxes. There's a statewide box, there's the MHSA revenues, MHSA expenditures, and a closing balance. And we have data in there showing percent change from the prior year. And so if you can see in that MHSA revenue box, it shows, and this, as you can see in the far left, this is for the fiscal year 2021. So this is not point in time today, it's as of the end of fiscal year 2021. Thank you, Cody. And each of these boxes you can scroll over. Our team has just done a phenomenal job in developing this tool. But you can see there's a 49% increase in revenues statewide over the prior year. Expenditures also went up. They didn't go up as fast, and you can actually see that in the color chart underneath. And there's a closing balance of $2.452 billion. It's listed in millions, so but it is $2.452 billion. The color chart, the blue is revenues, the gold, it may look slightly different on your screen, is expenditures. And so you can see the volatility in revenues, and the graph that is highest shows you on a given fiscal year where revenues were relative to expenditures. So for the past few years, revenues exceeded expenditures, except for 2018 and 2019. In 2019, there was a dramatic increase in expenditures over revenues. And for the 2021 fiscal year, you can see that big bump that the chair mentioned in terms of revenues. So revenues went up, expenditures went down, and that in part contributed to that significant closing balance. The graphic below, if you could scroll down just a little bit, shows you the composition of the unspent funds, with that top layer being CSS funding, the lighter blue PEI funding, then innovation, and then the smaller amounts in terms of workforce education and training and capital facilities and technology needs funding. You can see also how the makeup of the unspent funds changed over time. This is the overview page. If you could scroll up, there are some tabs across the top. Very quickly, this blue tab, if you could click on that MHSA details, Cody, this shows you the information for individual counties or statewide, and it shows you the makeup of the closing balance. So scroll down a little bit. And so what this shows you is the fiscal year from which the funds that remain in county accounts were drawn. And so this is data for the 21 fiscal year, and it shows most of those funds came from 2020. So counties are spending their dollars a year to a year and a half after they receive them, and we can see that in the 2019, the amount of funds from 2019 that were still held in county accounts in 2021. Go up again, please, Cody. We added this innovation encumbrance tab, which, there you go. And the goal here was to help counties avoid innovation reversion. We wanted to keep track of the funds that reports show are in the accounts and the innovation funds that have been encumbered through the Commission's approval process. And so this is designed to reflect those funds that are encumbered. One of the things we want to note is that in that $2.4 billion figure includes funds that have been, they're still on hand and they have been encumbered. And so there's a note to try to highlight that. And we do have the detail here on the innovation piece. And there's a couple more tabs, some comparisons. This tab allows a user to compare expenditures, revenues, closing balances between multiple counties. You can look at a single county or groups of counties. The next tab gives you access to the actual data, which can be downloaded. And then this long-term view tab is exactly that. It shows you trends in expenditures. Each of these, as we've shown you, is a statewide picture, but each of these 6 tabs allows you to pick a particular county. Please go back to the overview, Cody. So again, the purpose of this is to try to provide point-and-click access to existing public information about revenues, expenditures, and available balances. It's complicated data. There are some anomalies in the data. We update this every month as new reports come in, or every year, depending on the frequency of the report. And this is part of a broader strategy that the Commission has embraced to work to really do 3 things. The first is to create clarity around funding. The second is to provide access to clear and reliable information on the programming that is available. And in many ways, the most important is to provide compelling information on the outcomes that are being achieved through those programs. The outcome work is the most difficult. It's very complicated. But today, we're really highlighting this first component, which is finances. And so we wanted to just bring you up to speed on the work we've done, to be explicit about the changes we were able to make to accommodate concerns expressed by the counties and other partners, but also be clear on the concerns that we weren't able to address. And so I just want to welcome Phoebe Bell, who's been a phenomenal partner on behalf of both Nevada County and CDHCA to provide some comment and context on this information. And unless commissioners have questions for me you want to take now.
Toby, this is Commissioner Mitchell. I just have one quick question. And I applaud you because this is work that's been going on since I've been on the commission. Beautifully illustrated. But why are those, can you put that slide back up with the overview, the one slide that shows all the various categories? Can that slide go back up? Yes, this one. Why is this showing in millions if it's in billions? I mean, why is that a M versus a B?
For most counties, the closing balance, so Cody, if you could select any county other than Los Angeles, it's a design, and we could possibly try to redesign it to add the B when the B is necessary. But 95% of the time, the figures are shown in millions. So it does become an awkward 2,000 million. So I can ask our technical people if there's a way to design it so the B comes up, but that actually might be a feature of the way the tool is built. But as you can see here, it's actually millions. The only exception is statewide and at certain points in time, Los Angeles. But I think, yeah. So, but we'll see if we can fix that, Commissioner Mitchell.
Thank you. I have more comments, but I'll keep them to myself. I'll just let others.
Are there any other questions or comments from the commissioners for Toby?
I just want to make one observation, and I'm looking forward to hearing public comment to ensure that this type of tool and the information it's presenting is understood by the public, and a useful resource, right? I think that's ultimately what we want to get across with this transparency. I think across the board, for many of us that work to better understand how our public dollars are being used in our communities to meet the needs of our communities. This type of transparency is very important to hold our elected officials, our government officials accountable to where these resources go. So just want to appreciate that effort as underlying that, and appreciate the effort to refine it so that it works in the best way possible for all of us. And the one observation I want to make when I read these materials and been reading about this is just the incredible amount of money that we've seen grow, right? The Prop 63 resources come as a result of the number of millionaires we have in the state of California. And during the last 2 years, that was the hardest for our most marginalized communities. We've seen these resources grow exponentially because there were many on the upper end of the income threshold that have benefited from this very difficult time. And I want to acknowledge that and put it on the record that we've got lots of people doing just fine, and so many of us that are not. And for this transparency tool to tell the story that we have an opportunity to use these resources to help those that have been hardest by this pandemic. There's no clearer way to present that data than this tool. And for that, I appreciate that we're trying to tell that story to our members of the public so that we can be held accountable for the use of these resources. So just a comment, looking forward to the public comment.
Cody, if you could put the tool back up and click on statewide and the PEI component, just for example. So this is the 2021 fiscal year, and this will show you that for many years, you can see the incredible increase in PEI expenditures from 2016 to 2019. So that's that gold mountain growing, right? And revenues were higher than expenditures in 16, 17, 17, 18. They were, and then revenues started to expenditures exceeded revenues in 2019. So you can see how revenues began to decline. And so expenditures were well above annual revenues in 2019, and in 2020 it changed. This is just for PEI, and I mentioned PEI to your point, Commissioner, about ways, and there's some of the topics that came up earlier from the public comments. The Department of Finance is projecting the increase in revenues from what you see here, the 2020-21 year, to next year's fiscal year, that will be about $1.5 billion greater than the revenues that you're seeing on the screen here. So, I think the conversation we can support with creating that clarity, and again, it is a projection, so we're not clear, but we also know that needs went up dramatically. And so I think what we're trying to do with this is to facilitate the community conversations around how can we, one, recognize the volatility in these systems, right? We don't want to pretend that that's not true on the revenue side. We want to recognize the drivers around expenditures, and the pandemic clearly has resulted in this dramatic decline in spending, even though this is PEI funding that you're seeing here. And now we have this opportunity to think about tremendous growth in resources. And although it may be short-term, as evidenced by the history of revenues under the Mental Health Services Act, we do have a short-term opportunity of tremendous new resources. how can those be invested in ways that can strengthen the underlying system, and particularly through prevention, get in front of the kinds of challenges that we see are impacting our communities across the state. Thanks, Cody.
Thank you. So, Toby, we will move on then before comments to Phoebe.
Hi.
Hi, Phoebe. Thank you so much for being here.
Thank you for having me. And good morning, commissioners and members of the public. I'm Phoebe Bell. I'm the Behavioral Health Director for Nevada County, but also the president of CBHDA. I'm going to try to share screen quickly. You guys seeing a presentation, hopefully? All right.
Yes, we are. Thank you.
Great. Well, again, thank you for having me today. And I really look forward to engaging in this conversation. I really appreciate the points, the framing that Toby just provided and the points that many of you were making as commissioners. And I think there's some really important dialogue to be had around this topic. So I wanted to start, even though we're here to talk about the actual fiscal transparency tool, I wanted to start by talking a little bit about why this tool is important and why this conversation is important. And I think I'd like to start with what I see as our shared ground, shared between us as behavioral health directors, you as commissioners, all of you as members of the public and stakeholders in these important dollars. And that is that we all are committed to being good fiscal stewards of these funds. And to me, that means that we spend our funds in accordance with all the legal obligations we have, complex as they may be, but just as importantly, that we spend them in accordance with ethical obligations. And I think in part that means getting the money out the door to the people who need it when they need it in an efficient and effective way. I think it means doing that in accordance with really meaningful community stakeholder processes so that spending is reflective of what our community needs and wants. And I think it's important that we get that money out the door in a way that's sustainable and stable, that we avoid starting programs and stopping programs and restarting programs, because we know that erodes trust in community and isn't a particularly ethical way to provide services. And then lastly, I absolutely believe that the transparency work that you're doing is a critical part of that good fiscal stewardship, and really appreciate how much energy and resources you have devoted to doing this and getting this information out to all of us in a way that's clear. And I think it's also important to, in that vein of transparency, to start with kind of the big issue on the table, which, as many of you addressed, is this reality that right at this moment in time, there's a lot of money sitting in fund balance, $2.4 billion. It's a lot of money. And I am certain that if I were in your shoes, I'd be saying, what's going on here? Why is this money not out the door? We have unprecedented need and unprecedented resources. And how do we meet this moment? And what I'm hoping we can do today is give a little bit more context to why that number looks the way it does. And also hopefully think about ways we can partner in addressing some of the structural challenges we face, but also partner in how we tell a meaningful story about these numbers in a way that is complete and holistic about the situation. So first and foremost, I think we have to all remember that we are looking at a point in time at the end of an unprecedented 2-year stretch of a global pandemic. And I know we all know that, but I'm also amazed by how quickly I'm forgetting everything that's just happened. And I'm very briefly going to walk us through a quick timeline of what's gone on in the behavioral health system for the last couple of years. 2 years ago, we came to a screeching stop as society. In that moment in time, demand for services slowed down, and most importantly, revenue started dropping precipitously. And at that moment in time, all forecasts were pretty dire that they would continue to drop for a while. Over the next few months, demands began to increase, and we realized, wow, there's going to be a significant behavioral health impact from this pandemic, and needs are growing. Around that same time, we started to realize that we were having some workforce challenges. And it turns out that being a frontline behavioral health care worker in a global pandemic is right up there in challengingness alongside being a primary care provider in a global pandemic. Our staff were leaving positions. There's a lot of turnover, a lot of burnout. It was stressful, hard, dangerous feeling work. And in this moment when we were having this rising demand, we were having really a workforce crisis, and to the point where our ability to provide services was being hindered by the bodies we had to do the work. So coupling workforce crisis and demand, suddenly revenues started skyrocketing and to well beyond projections, incredibly high levels of revenues. So this COVID situation landed on the top of what was already some structural challenges around how we administer our MHSA dollars as behavioral health departments. I know you know this, and Toby as well touched on it. The green line being MHSA funding, it's a super volatile funding source. The red and blue lines being our realignment funding, which is a little bit more stable. I know for me as a manager of these funds, what I'm aiming for is sort of that through line. How do I hit that midpoint through this up and down trajectory? I can't spend at these highs because then I'm cutting terribly at these lows. And again, back to eroding trust in communities. How do I provide a steady and dependable stream of services with funding that goes up and down like this? That's significant challenge number one. In addition to being incredibly volatile, MHSA dollars are incredibly unpredictable. And I can't understate how challenging that is as a behavioral health director. This chart shows, governors' projected revenues versus actuals, and you can see how wildly off these numbers can be. 7%, that's not too bad. 22% to the bad, 31% to the good. That's really challenging to manage. And at the end of the day, you don't know how much money you're going to have until you have it in the bank. You build your budget based on some projections, you hope they're good, and then everything changes, and you don't even necessarily realize until partway through the year how much it's changed. So that poses a challenge. And the good news is, what we know about behavioral health departments is we're actually very excellent at adjusting for that. So typically we don't get the money out the door in that first year because, again, we might have projected something very different from what's coming in the door. But by year two, we are spending that money. This is a chart that DHCS put together that lighter color blue is the year two spending. So very little of our money actually reverts, less than 1%, because we're really getting it out the door in that second year for the most part. Other challenges I won't spend a lot of time on, but to getting money out the door quickly in the midst of a unprecedented upswing. The community planning process, incredibly important. We value it highly. We want to do it with integrity, and it slows things down. I can't midstream add a giant new program if it's not in my 3-year plan. More importantly, I want to make sure my community wants and needs that new program. So we need to work together with our community stakeholders to go through this process. Also, we need to spend our money in specific buckets, which is, of course, important. But what's important to also recognize is the ratios baked into these buckets. And how that plays out for me, for example, is with my CSS dollars, 51% of my funding needs to and should go to full service partnership expenses. What's challenging is in a year like we're having with the workforce crises we're having is our full service partnership programs are having a hard time expending at the level we need them to expend at. In Nevada County, we have 2 providers, one of which is Turning Point. I see Al on this call, a phenomenal partner. We love them. And Turning Point struggled with vacancies in Nevada County, 25% vacancies. Between our 2 FSP providers, they're coming in 23% under budget, most likely. That's expenses that didn't happen, so that lowers my expenses, but also I can't now spend on this side in the same way, the CSS side, because my ratios will be off. And so that problem can also hinder quick spending, depending on what your challenges are that you're facing. So this is a quick little personal journey through Little Nevada County and our revenues, but just want to underscore that volatility piece, down 2%, down 14%, up 64%, unprecedented. This slide was at a community meeting we did a few months back where we were projecting 1% up for this year. This was mid-year, and it's turning out we're coming in more like 3% up. Back then, a few months ago, we also thought we'd be down 13% next year. We just recently got numbers saying we'll be up 10% next year. And then we got more numbers saying, well, Nevada County's share of that is actually not as big. So Nevada County, you might only be up 2 or 3%. So I'm building my budget for next year right now, dealing with 3 wildly different projections of how much money I'm going to have in this pot for next year. And it's a really hard way to manage funds. And so, rightly so, I'm focused on getting this money out the door and probably not going to get next year's money out the door perfectly in alignment with how it ends up coming in, because I'm not sure how it's going to come in. The good news is counties are being incredibly creative and flexible and working hard to meet the need. And again, back to that moral imperative we all feel of meeting the need. In Nevada County, we mid-year did mini grant programs. So in accordance with our 3-year plan, we reached out to all our providers and said, what needs do you have? How can we help you right now? And got many, many grants out the door, another 25, 30 grants out the door. I was in front of my board of supervisors 2 days ago to purchase a house for our FSP population. I know in talking to directors in other counties, in Sacramento County, Ryan and his team have raised rates midstream and added capacity to contracts in hopes of getting services going. Talking to John Sharon in LA, similarly, raising rates 10%, working really hard to get money out the door. And meanwhile, my numbers are pretty small. For him, he projected $100 million lower revenues, and it came in $100 million above projected. So that's a lot to pivot midstream. So having said all that, back to the actual tool, we really appreciate the work that staff has done to be responsive to some of the concerns we had, and really believe that we are getting to a really good place with this tool. I think there's still a few pieces that are, important to recognize. As Toby indicated, there's some places where encumbered funds are recognized and others where they're not. I think that the 3-year cycle of these funds is pretty important, because that's really how the money comes in and how the money goes out. And so if there's ways to better reflect that 3-year cycle process, I think that would be really helpful. But probably more importantly, I think that the moment in time we're at right now really highlights some of these structural challenges I was speaking to about MHSA as a funding stream. And we'd love to work with you and partner with you on ways to mitigate some of those structural challenges. And I'd say just as importantly, we would love to partner with you on ways to communicate about what's going on with our funds, which is ultimately the point of this transparency tool, is telling a full and complete story of the work that's being done to provide solid and ethical and meaningful stewardship of these important dollars. So with that, let me figure out how to unscreen share, which it's not letting me do at the moment. There. Thank you so much for the chance to speak to this, and be happy to answer any questions.
Thank you, Phoebe. Commissioners, any questions or comments to that presentation? Commissioner Rolette, please.
I think I would be remiss if I didn't acknowledge that Phoebe's presentation, and especially the comments about being a partner in Nevada County. Specifically, I also recognize the unique challenges associated with managing a community-based organization and working with county partners in a very volatile environment, especially given the factors associated with attracting and retaining a workforce to do this very important work that I think we're all privileged to do, and the inflationary factors that we face today and the unknowns going forward. Yet, in the midst of that challenge, I also underscore, I want to underscore, excuse me, better said, the pillars that I would describe them that Phoebe initially illustrated, and the importance of those pillars as it relates to this tool. My hope is that certainly at some point we will have this tool being endorsed by County Behavioral Health as well as the Commission. Thank you.
Thank you, Commissioner Rolette. Commissioner Carnevale, please.
Thank you, Chair Madrigal-Weiss. As a business representative on this commission, I feel an obligation to weigh in here a little bit. This is a very challenging issue. It sounds like it's an issue we all feel the same about in terms of the obligations to create transparency and be evidence and data driven here. And I think that's just crucial, but this is a very technical area. And the thing that jumps out at me is that this is not, these struggles are not new. Businesses face these problems all the time. But there's one tool that businesses use that I don't see contained here. Contained here in this data are the income statements and basically a cash flow statement. But what's missing is the balance sheet. And for any of you that are investors or follow investing much, I mean, it's the balance sheet. Warren Buffett will tell you it's a balance sheet that contains all the real critical information of problems and opportunities in companies. And the same is true here. Without being able to see the various assets and liabilities that are contained in the system, so you can see what's been encumbered and what hasn't been, and what's short-term and what's long-term, it's hard to really tell the complete story. So I understand, the frustration of the county and also the desire of the commission to highlight and the importance of highlighting the money and how it's being spent or not being spent. But that, to me, the answer is not, well, we have to save the money because we're not sure about the future, because the only constant here is that you're going to have change. You have volatility all the times in business, and there are lots of sophisticated business tools that in finance that take this into account. And it just jumps out of me that somehow we're missing something in the planning cycle here between the cooperation of the counties and the state to drive these decisions. So I guess without going into more detail, I would encourage that conversation around finishing. I mean, this is what's been created is fantastic. To me, there's a piece that's missing that would finish this and would allow us to be able to tell the full story that hopefully is satisfactory to everybody and highlights, I guess my only opinion on this is that saving money is not the answer. We have money that's created in order to solve problems, and saving it because you're not sure you're going to have in the future is not the right answer. We have to have systems that allow us to be able to project and manage those various deficits, and those are possible to create. So I think this is a great conversation, even though it's more of a technical nature about how the commission operates rather than the actual works and programs that we do. Thank you.
Thank you, Commissioner Carnevale. Vice Chair Alvarez, you want to?
Thank you, Chair Madrigal-Weiss. And thank you to Commissioner Carnevale and to Phoebe for the presentations. I learned a lot actually in these last few minutes. So thank you for that, for the opportunity to engage in the learning journey. I do want to pick up on Phoebe. You're saying these structural challenges with MHSA resources, and it's interesting because it's not only county behavioral health departments that are saying that, community partners also say that, right? So there is an across the board need to potentially explore what those changes are in order to be more effective in the delivery of our resources to communities in need. And as a commissioner, I would really encourage us, and this isn't like going to happen overnight, I get it, but it is a long-term commitment to really looking at the MHSA and ensuring it is set up to meet the needs of our communities most effectively. And I say that because, again, I know I talk about equity a lot, but as we talk about equity and our commitment to health equity, it's dismantling these structural barriers that operationalizes our commitment. And part of it is working with our county partners, our community partners, to identify what those barriers are that we need to break down in order to get these resources in the hand of those that need it most. So I want to express my commitment as a commissioner to do that, to talk to staff and figure out what that might look like. Again, over this long haul, and I have no idea how long I'm going to be a commissioner anyway, but just really thinking how we can move forward with that commitment. So thank you for that.
Thank you, Vice Chair Alvarez. Yes, please, Commissioner Mitchell.
I would like to kind of tag on to Commissioner Carnevale's statement as well, because I'm not a budget person, but one of the things that I did pay attention to his comment was regarding, finding that tool that would help this commission as well as the counties project or work with these volatile moments and or these unpredictable budget cycles. We can't control, the revenue flow. That's just the obvious. But what I do appreciate is the fact that as a business person, there perhaps are tools out there that we have not considered that would help us to do some projection work. I know that projections can be off, they're off all the time, but there has to be a tool that can be utilized so that these services do get delivered so that we're not looking at encumbrances and unspent funds year after year because of we don't know what the future holds. And what we do know that here and now, if I were to come down to our commission office, I'm probably, as I said 4 years ago, I'm probably still walking and stepping over, stepping around, lots of individuals who have unmet needs, severe mental illness, and I would hate to think that these are some of the same people who have been outside this building since I've been on this commission. So my point is, I really, and that's an extreme example, but I really would like for us to explore whatever those projection tools of accuracy or volatility, whatever we can do so that we can go ahead, counties, and expend those funds for programs that are serving the most needy in this state, because these dollars are probably unheard of in any of our other states. And so there is no budget problem. There's a budget problem in terms of the implementation and the management, not, the management in terms of mishandling, but our fear of what the future holds. And we know that we need to address many of these problems here and now. And so that's what I would encourage the commission to allow staff or whomever to explore whatever those tools are that can ensure some greater sense of reliance in expenditures.
Thank you, Commissioner Mitchell. Commissioner Gordon?
Thank you, Chair. Very briefly, I know we have to move on. First of all, I really want to commend Toby and the commission staff for pushing on this transparency tool. I think it's a huge leap forward from where we've been. And I also want to give a special shout out to Commissioner Carnevale. Thank you, Governor, for bringing Commissioner Carnevale onto the commission, because you're raising issues that badly need to be considered. And the final point I wanted to make is we're very fortunate in our county to have a very strong relationship across our agencies, whether school agencies, county health agencies. I think that's ever so crucial, but transparency really contributes to that. And we've had a lot of internal discussions on how we ramp that up. And if we could push on the end of results and outcomes and what are we looking for, I think that would contribute to a lot more collaboration among both our agencies, but also our nonprofit partners and most of all with our clients. So thank you.
Thank you, Commissioner Gordon. I would like Toby to respond to some of the comments that our commissioners made, just as far as, how the work that has been done and what was lifted. But before I ask Toby to do that, Phoebe, I want to thank you for the presentation. I appreciated that you started with, the fact that you have the fiscal stewardship and the ethical obligation to use these funds, and that you want to do things that are sustainable and stable. And I appreciate that. I see this transparency tool at exactly that, as a tool to really inform local conversations with the community. So I saw this as something that would help build the relationships. And so knowing that you have those key principles in mind and really bringing along the community with the information to be able to guide those conversations, I think is a critical piece. So I appreciate your presentation and everything you said. I think that is very important. And I hope that our community knows, exactly why we're so committed to this transparency tool. And so with that, I would like to invite Toby, please, if you could just share with us, as we continue to move forward with this and some of the work that has been lifted and just response to some of what our commissioners have said.
Thank you very much. And I want to just shout out to Rachel Heffley and Jing Shen, who really are the masters of technology and the data and helping to make this dashboard, this visualization tool possible. So they've just been phenomenal. Again, our goal is to support exactly the kind of conversations that you're having today so that the community can understand volatility in the revenue, the kinds of decisions that are being made. It's really about informed consent. It's really about making sure that we have this robust community planning process, and there are some foundational information needs to support that. We are really trying to push on the outcomes piece, which again has come up every time the commission meets, particularly around approving innovation plans. How will we know if the outcome is, if conditions have improved, if outcomes are better, if people are better served as a result of these investments? That's harder to do, but this is a foundational step in that direction. In terms of some of the specific comments, Commissioner Carnevale, I'd love to work with you to understand the assets and the balance sheet and how that works in the public sector. We've really tried to find models in the public sector that we can emulate, and at the same time have tried to be very responsive to the kinds of concerns or questions that our community partners have asked us to answer, which is why the tool is designed around revenues, expenditures, and balances by component, by county, and over time. But I will reach out to you to see if we can better understand the pieces that are missing. One of the opportunities that I think we just have to recognize is the state that what's not reflected here is prudent reserve amounts. So these funds do not include what we might call a rainy day fund that counties are allowed to have. A few years ago, the legislature capped the amount of money to, I think it's 33% of the funds from the community services and support component. The average of a 5-year balance of community services and supports, 33% of that can be held in a prudent reserve or a rainy day reserve. That may be low, given the exceptional volatility that Phoebe highlighted with the data that she showed, particularly relative to their other funding streams. And there's another challenge, is counties don't actually have easy access to those funds. There are some considerable limits in whether or not they can access those dollars. And it's tied to the economy. It's not necessarily tied to needs. So that may be an area worth exploring. How might we strengthen the ability of the counties to address volatility? And in doing so, does that sort of free up the opportunities for county boards of supervisors and their community partners to make more dynamic use of dollars, even because we're not, as Commissioner Mitchell and others have said, we're not going to address the volatility in the fund, but maybe we can address the flexibility with which counties have access to those dollars. The last thing I want to share with you is this tool displays the MHSA revenues. MHSA is a component of overall public behavioral health funding. It doesn't reflect, I have said publicly before the legislature, we can tell you a lot about one of the tires on your car. This doesn't say anything about the other sources of funding. And one of the things we've been trying to do is to actually tell the complete picture of mental health revenues and expenditures. And I think that actually also will help communities understand that counties are generally making very good decisions, very reasonable decisions within the constraints that they have. Sometimes those decisions are hard to see because of the information that's not included, like encumbrances or volatility or what's happening in the other funding components that counties rely on. So we'll very much work to continue to improve this tool and make sure that we're responsive to the needs of our county partners and other community partners. Thank you.
Chair, if I may, could I make some comments back on what Toby just shared?
Please.
And thank you. And Toby, thanks for bringing that up. I think there's a lot of value in exploring your idea there around sort of expanded access to and definition of and utilization of a more viable prudent reserve. Because I think, again, back to that fiscal stewardship concept, I hope what you took away from what I said is that is our goal as behavioral health directors. And we are trying to figure out how to manage appropriately, again, in a way not to be imprudent with our spending and not to break trust with our community and create expectations we can't meet. But I would love to be in dialogue about working together. What does that look like? What is prudent and thoughtful that we can all agree on so that we can all share that story collectively to the broader community and make sure that these funds are used for what they're meant to be used for and to that intense need that you're all speaking to. And I couldn't agree more. We need to meet the need as best we can and as is reasonable. So appreciate that idea a lot.
Thank you so much, Phoebe. And absolutely I did. That's exactly how I intended it. And I appreciate that. And again, as I said, this is a tool that brings that conversation together. It is not us, them. This is really a we. And it is a we between your organization, the OAC, and of course our community. And so, appreciate your comment and thank you so much. Toby, thank you for that. At this time, we are going to ask for public comment. So please, this is a reminder that members of the public should be prepared to complete their comments within 3 minutes or less. And I see no other commissioners. I don't want to jump ahead. I think we are good. All right. So with that, I am going to ask, please note that the meeting moderator will unmute your line and announce your name or the last 3 digits of your telephone number. Once unmuted, we can hear you. So Mariani, please open the line for public comment on agenda item number 5.
Okay. Ryan, your line is open. You may go ahead.
Good afternoon, commissioners. Thank you for the opportunity to make a couple of comments. My name is Ryan Quist. I'm the Sacramento County Behavioral Health Director. I'm also the Vice President for CBHDA. And I want to echo Phoebe's support for supporting some of the conversations that Toby had been suggesting around prudent reserve and the other solutions that were being discussed. I wanted to take an opportunity just to sort of illustrate some of our other experiences here in Sacramento County to sort of also reiterate some of the points that Phoebe was making. In the beginning of COVID, we experienced a significant, I'd say, whiplash in terms of first, we were under the impression that our funding was going to be dramatically low and come in very low to the point where we began having to have significant conversations with our communities. And Commissioner Roulette was part of those conversations and was very helpful in helping us think about, okay, if our revenue is going to be down, how are we going to do some cuts in a thoughtful sort of a way? Thank heavens we spent 2 to 3 months on that. But thank heavens we never had to implement any of those changes. And it did turn out that we ended up having our revenue up. So I want to tell you about some of the things that we have been very successful at doing during COVID in terms of trying to meet the demands in the moment. Early in the pandemic, you might remember there were a lot of conversations around systemic racism. The disparities, and particularly health disparities, were highlighted within our diverse communities. And so as a part of our prevention and earlier intervention initiatives, we were able to put out $10 million worth of community-based funding for proposals that benefited our most diverse communities. I'm looking at my list of the programs, and I just want to read very quickly some of the populations that they served. Low-income African-American families, LGBTQ, transition age youth, racial ethnic groups, African American, African Latino, Afro-Caribbean women and young ladies, Southeast Asian. You sort of get the idea that these were ideas that came directly out of our diverse communities in order to be able to actually end up addressing the issues in the moment. And along the way through the COVID, we also were able to stand up some new programming around adult residential treatment. We stood up new programming around augmented boarding care. We made some improvements for housing flex funds as it relates to, being able to get people into housing. We made improvements and expanded the availability of our housing flex funds. And then most recently, we, responding to the community, we did expand our urgent care to funding. We provided funding for it to expand to 24/7, but that was right before Omicron. And so Omicron made it difficult for us to be able to expand those services. And that was a Turning Point program. So again, we're all in this together in terms of trying to figure out how we're going to make this happen. The feedback I got from providers was that they weren't able to successfully recruit and retain staff. So Phoebe mentioned, we increased our rates by 10%. We increased our capacity in our entire outpatient system by 7%.
Brian, thank you. Your 3 minutes are up. Please wrap up for us. Thanks.
Thank you. I appreciate it. I just wanted to illustrate some of the advances and efforts that we make during COVID. Thank you so much.
Thank you, Ryan.
Next, we have Michelle. Your line is open. You may go ahead.
Hi, good afternoon, commissioners and members. Michelle Cabrera, Executive Director for CBHDA. And I first wanted to say thank you to the commission. Thank you to Toby and his team for the collaboration across the development of the fiscal transparency tool. As Phoebe mentioned, transparency and fiscal stewardship are important goals that we share with the commission, and we very much value the conversation today, as well as the opportunity for our board president to share some of the county behavioral health director's experiences in managing MHSA funds. To Commissioner Carnevale on the business side, I was smiling when you made your comments because I actually was reviewing a Fitch bond rating of our No Place Like Home MHSA bonds, which are financed through county behavioral health. And, Fitch, which is one of the premier, fiscal forecasting entities in the world, talks about MHSA's volatility, talks about how sensitive our millionaire's tax is. And so I really appreciate Toby's, willingness to sort of lean in and step back and go, okay, if this is more of a structural issue and we're really talking about counties trying to sort of manage those peaks and valleys, and if a county, the example that I'll give is sort of if a county were to try to spend too close to the money that they have today, they're going to be in a position, potentially tomorrow where they're having to make dramatic cuts, and to providers and services that their community can hardly, afford to lose. So I really appreciate the sort of creative problem-solving approach that Toby's taken in trying to address what we've experienced over the course of the pandemic. So really valuable, and we look forward to partnering on further exploration of those ideas. I'll leave you with one more really businessy note, because I realize that the more important thing is the community need. But we found that with the state estimates that we rely on to do our community planning and spending, we looked at the last 4 years and found that when the state underestimated revenues by approximately $500 million in fiscal year 2021, our closing balances increased by $468 million. And then in 1920, when the state overestimated by $370 million, the closing balance decreased by 251 million. Those numbers are so close, it kind of makes me think that there's a relationship there. And so I do think that some of what we're trying to solve for here can be solved for, and really appreciate our engagement, because we want to be able to spend responsibly and to address community needs as quickly and as thoroughly as we possibly can, and learn from this pandemic experience. So thank you.
Thank you, Michelle.
Okay, next we have Tracy. Your line is open. You may go ahead.
Good afternoon, commissioners. My name is Tracy Hazelton. As you can see, I represent Alameda County Behavioral Health Care Services. I'm the MHSA director here in Alameda. And I just wanted, my comment will be very short. I wanted to say I appreciate the work of the commission and the disclaimers that have been added to the fiscal transparency tool based on previous county concerns. And so we really appreciate that work. However, we do still have some concerns in that the tool can be complicated to read with the disclaimers. So I heard from Toby today that there may not be a date to release it yet. So one is a question about, is there a date that it will go live? And if not, if counties could be notified so that we can be prepared at the county level to be able to start to engage in those discussions with our communities. So that's the one question, the request about the date. I also want to say I really appreciate the conversation about prudent reserve and making that potentially a lower barrier for counties to be able to utilize those funds and then plan for volatility, because the volatility piece is something that counties are concerned about. And then as a final piece, I just wanted to highlight Commissioner Mitchell's comments around new or enhanced projection tools, because that's again something that if counties could have better projection tools, we would be able to plan farther out and get as much money into the community as possible. When we have volatility, these are services, and so we do not want to start things that we cannot continue funding. And so those are just some highlights from today, and we just really appreciate the conversation today and being able to engage in next steps around our funding. So thank you.
Thank you, Tracy.
Steve, your line is open. Oh.
Okay, thank you. Hi, my name is Steve McNally. I'm from Orange County. I am on a state mandated county behavioral health advisory board. I'd ask each of the commissioners to look at WIC code 5604.2 and ask why the shalls aren't really being done across the state, because it would affect a lot of things and correct some things. This is a complicated issue, but the biggest complication, I think, and I'm speaking as an individual, not for my board, is that in our county, the CEO is handling all the financial reporting now. And I think that's important because to Commissioner Carnevale's comment about cash flow, our plans don't have cash flow in them. We don't report expenditures on a monthly basis, though we do collect the information from contracted providers around the 20th of the month, but we don't report it. And so you have to go to the county controller or auditor to figure out through their comprehensive annual reviews reports to get a cash balance, see what's going on. The CEO can always provide you a cash balance. So the balance sheet can be done. It's not that hard. So I guess what's really hard for me is that the issue here is transparency and managing expectations. And I don't speak as eloquently and more directly than you all like to speak to each other. But families are not making it through the journeys intact. People aren't making it through the journeys alive. And if we can't get some urgency to this and put our egos in the closet, we got a real problem. And so nobody has ever stopped CBHDA from publishing reports on a county basis. How much FFP is being achieved in each county? It is very dramatically different. And CalAIM's based on federal funds participation. How much community planning? We could spend 100 million a year by law. Some counties don't even report it on the annual revenue and expenditure reports. So I'm not attacking anybody. I'm just saying this is the real world. And we don't not show information because we don't manage expectations well. We show information, explain it, and then get communities to embrace it. And as a gentleman from Sacramento said, responsive funding mechanisms that allow smaller organizations and ethnic communities to get outside of county procurement and have informed and not necessarily evidence-based will allow them to participate. Counties, I'll use our county as an example. Contractually, contractors can't talk about outcomes. They can't talk about anything without approval of the healthcare agency. The second thing is that procurement pre-COVID, at least 9 months. Now everything's a lot of sole source. Sometimes we don't even get anybody to respond to RFPs. And then
Steve, your 3
hiring,
minutes are up. Please wrap up for us. Thank
and
you.
I'll wrap up. And hiring is at least 9 months as well. And that's pre-COVID. So, you know, when John Sharon and Veronica Kelly are the two people I've heard speak openly on this topic, and I go to a lot of meetings, everybody else wants to sort of hide behind it. And we got a 31% open rate in staffing in those 2 counties. We got, anyway, I apologize, you know, don't take my comments as being angry. I am frustrated, and it's not about who does what. It's about, let's get focused on what MHSA is about, the sickest, most vulnerable people in the state. Thank you.
Thank you, Steve. Toby, I would like to loop back if you could just respond to when we plan to go live.
Well, let me recommend that we would work with the chair. We'd work with you, Madam Chair, to identify a go live date with a goal between now and the next commission meeting in April, if that's acceptable to you.
Sounds great. Yes, thank you.
And we'll give a heads up to county behavioral health directors and other partners before that happens. Thank you.
I appreciate that, Toby. Thank you so much. So hearing public comment, thank you, Amarani. We are going to move forward. Thank you, everybody. Phoebe, again, thank you for your time and for being here. For those of you that shared public comment, thank you for that. And Toby, for your presentation. We will move forward to item number 5, elevating the commission's voice on racial equity, the racial equity plan. So on our last item, the commission will hear a presentation on work being done on the draft racial equity plan. As you know, the MHSA explicitly calls attention to reducing disparities. As a reminder, commission staff have been working on a racial equity plan along with 36 other state agencies, all led by the Governor's Strategic Growth Council. Last year, we heard a presentation from Commissioner's consulting psychologist, Anna Nathy, and the commission's Chief of Administrative Services, Lauren Quintero. Today, they are back to provide an update. In your packet, there is a draft of this plan for you to consider. This is a first read, and we will reserve time at a future commission meeting for a second read, where we hope to have a more detailed discussion and consider adoption. So please focus your questions on the process to develop this plan. We want to make sure there's ample time to review and comment. Members of the public may request to make a public comment on item 4 by clicking, not item 4, we are on item 5, my mistake. By clicking the raise hand button on your computer or the app, or by pressing *9 on your phone. Once the public comment period starts, we will close the public comment queue. So please make requests to comment now or as early as possible during this presentation. So I would ask Anna and Lauren to please be ready and go ahead and share your presentation with us.
Sure, let me get that on the screen. Okay. Hi, everyone. I'm Anna Nathy, the consulting psychologist for the commission. My pronouns are she and hers. I am going to present by myself today. Lauren is here, but will not be speaking. So we have in your packet a first read draft of our racial equity plan. And I wanted to talk a little bit today about how we got here, what we've done, and we hope to talk about this a little bit more in the future. So as you know, here's the mission statement of the commission, and we harken back to this because it really speaks to some of the things that we hope to use and amplify in our racial equity plan. We talk about transformational change. We know that—
Sorry, Anna, can I interrupt? Are we supposed to be seeing your screen?
Yeah, is it not showing?
No, it's not. At least I'm not seeing it. Is anybody else seeing?
You know what? It says it's paused. How's that?
Now I see it. There we go.
Yeah, okay.
Thank you. It's on the commission's commitment to transformational change in mental health.
Yes.
All right, we're good. Thank you.
So we know that we cannot transform the mental health system and address some of the needs that exist in our communities without addressing racial and ethnic disparities and racism in the system. And so that has been kind of the cornerstone of this work. As Commissioner Madrigal-Weiss mentioned, this addressing disparities is part and parcel of the MHSA. And so we are, lined up with that. We also know that, our lives are intersectional, that we have a lot of different— sorry, I'm having some technical problems. We know that that there are many different ways that that discrimination and bias affect our mental wellness, but by starting with racial equity, that we as commission staff within the commission are learning ways to address some of these structural barriers in our system, and that we'll be able to tackle other inequities throughout this process and as we continue moving forward. We also acknowledge the recent declaration from a variety of different public health entities across the state of racism being a public health crisis in our system, and also the governor's priority on this topic, as well as our former Surgeon General speaking to this as an issue that we must address. And so in 2020, in August of 2020, 16 of our staff, with myself and Lauren as co-leads, joined the Capital Collaborative on Race and Equity, called CORE. CORE is in collaboration with the Strategic Growth Council and the Public Health Institute. And it really is designed to help state governments, state entities learn strategies to address racism in both in their governance, but also giving staff tools. We had the benefit of having being in a cohort with 16 other state agencies that we shared learning with, that we could speak with, and that there was a staff team that provided technical assistance. We also, at the commission, we worked with a consultant, Dr. Tamu Green, who helped us along the way, and we met with her every other week as a team for 2 hours to talk about this topic and what we can do. A little bit more about some of the goals of CORE. The goals really are to help state entities learn strategies to build racial equity plans and planning process, to increase transparency, and then also to help help executives and leaders across the state to amplify this need, and so I think, as part of this process has evolved, we've had the opportunity to join with other state agencies and state leadership on prioritizing racial equity. So a little bit about our work to date. Wanted to say a special thank you to Commissioner Alvarez and the Cultural Linguistic Competence Committee. We've met with them many times over the past couple year and a half. We've met with them 4 times and talked about our racial equity plan. We've also met with the Client Family Leadership Committee and have done a lot of research both independently and with other agencies in this planning process. These are some of the tools that we've used. Part of what we got through this process was a toolkit, a toolbox of different ways to build our plan. And so we've gone through this process of using all of these racial equity tools to help us in our planning. And ultimately the goal is to create this plan. So what you have in your packet is a draft plan, and it covers these areas. We know that in order to start addressing racial equity in mental health, we need to start with ourselves, start internally, start with building capacity, and so that's where we are. And then this is a first racial equity plan for the commission, and so we do anticipate that as we continue along this process, that we will revisit this planning process and continue to grow and become more expansive in our thinking and be able to address racial equity across the system. So I think that's all for now. Very quick presentation. Thank you.
Thank you, Anna. Thank you. I really appreciate the overview and the huge lift that this work encompasses. So I appreciate that, Lauren, you in the background, and Commissioner Alvarez for inviting the group to your meetings and to the committee. And I'm sure for the feedback that you've already provided. At this time, I would like to invite any commissioners for questions or comments.
I also want to extend our appreciation to Dr. Nafee and team for all the work that they've done, and to the CLCC committee members and the members of the public that joined us for engaging in this conversation. I have a procedural question. So we're fortunate to have this draft report in front of us, or draft plan in front of us to review, and to also allow members of the public to review. And I think it presents an important opportunity to get even additional input from the CLCC, given that we have a meeting coming up in between. But I am curious, Dr. Nafee, how over these next 4 weeks, as we prepare for the upcoming commission meeting, what the receptivity to that feedback looks like, and what the opportunity is for influencing the process as it moves forward.
So, the purpose of putting this draft out there without, sort of confirming it today, was to give the opportunity to have to get feedback. So we would love to hear the feedback. We could talk with the CLCC again. We would love to hear the feedback in writing. And we want to incorporate thoughts into the final plan. And I'll also mention that we don't currently have the second read agendized at this very moment, but we'll obviously get back to you about when that will happen.
Sure, absolutely. Or the following, whatever time that we do have to review. Thank you.
Any other questions or comments from my fellow commissioners? Okay, I see none. Any public comments at this time?
Hi, Mara. Sorry. We had some technical difficulties in the office, and Katera would like to make a comment.
Yes, please, Commissioner Templin.
Okay, thank you, Chair Madrigal-Wise and Vice Chair Alvarez for this incredible work. It's a crucial step towards transforming the mental health system. Again, I want to commend Vice Chair Alvarez and the CLCC for championing this work, and of course, Executive Director Ewing and the OAC staff for their leadership and all the folks that have been contributing to this. And thank you, Chair Alvarez of the CLCC for coming to the CFLC and joining us to give inputs. This is just really incredible, and I just wanted to speak to that the areas that I mean throughout this draft plan. It just it feels very hopeful because especially like around research and evaluation, the leveraging and publicizing data that identifies racial and ethnic disparities and advocates for data collection to understand those disparities and hopefully creates an action plan and solving them is so crucial. We see, unfortunately, a disproportionate representation of Black and Brown communities in the involuntary system in locked facilities, experiencing seclusion and restraints, overuse of courts to coerce us into taking meds, and getting then ultimately access to much needed supports such as housing through that process versus a voluntary process. So identifying those kind of disparities is really important. And also under research, exploring and describing structural racism in policies and practices related to the system. These are, I mean, and then the communication piece, because sometimes a lot of these stuff are happening in our system that I don't think people are intending to do it, but communication about how this impacts Black and Brown communities particularly, and is critical because sometimes those voices aren't heard in our media. And I look forward to more work and support and actually making this difference in our state. So thank you for this incredible work, and just wanted to celebrate it.
Thank you, Commissioner Templin. I don't see any other questions or comments at this time from my fellow commissioners. So Anna, I look forward to really diving deep into this and offering more, contributing more to the conversation when we speak more to it at a commission meeting. So at this time, I would like to transition over to public comment. So if we could, Amirani.
Yes. We have one public comment. Stacy, your line is open. You may go ahead.
Hi, Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I really want to thank the chair and Chair Alvarez of the CLCC, because I was ready to make different comments because of this item getting moved towards the end, because I thought that the commission was going to adopt this final plan, again, without a lot of discussion. But again, thank you. Knowing that the CLCC will be looking at this again, I am totally comfortable. Although I wish that Anna had at least gone over the plan briefly with the commission instead of just talking about its development, because I think if commissioners are anything like me as a board member or whatever, even though they give you the material, if they go over it in person, it sticks more. But just using my remaining time, regarding the plan itself, it would be nice if there were a little bit more specifics, especially on pages 4 to 6. There are goals and objectives, but it is not clear who is going to be responsible for implementing them. And there are no dates attached to what the commission will do. But perhaps these will be added later or will be self-evident. Under the policy area, I believe that if the commission takes positions on bills that have a direct influence on affecting, reducing health disparities for people of color, that would be very good. For example, there is a bill that declares racism is a public health crisis, SB 17, that Senator Pan has, that I would have brought up during the legislative portion, but there was no general comment under the legislation area this meeting. I did not see any training in implicit bias, white privilege, or other timely and relevant topics for staff or the commission. Previously, the commission undertook a 1-hour training that was developed by the CLCC every year regarding cultural competence. Frankly, we thought it was woefully inadequate, but now there has literally been no training for the commission in areas related to this since the pandemic. But of course, the pandemic really did throw a monkey wrench into everything, so that is understandable. Lastly, I recommend that there's a point person for this plan, and maybe it is Anna Nafi, so that the public can continue to direct questions after the plan's implemented. But again, thank you very much. I'm very relieved that this will be going over further review. Thank you so much.
Thank you, Stacy.
And that was the last public comment.
Okay, thank you, Mariani. At this time, thank you everyone for joining us today to continue the work and discussions around mental health. We would especially like to thank members of the public. We always value your input and participation. Our next commission meeting will take place on Thursday, April 28th. So we look forward to seeing you all again next month. Today's meeting is adjourned. Bye, everyone. Take good care of yourselves.